Good morning. Welcome to NEET SS Nephrology Recall Session from Bengaluru. A very cold, chilly day here at Bengaluru, more frigid than anything else, I would say. And it's on this day that we are going ahead with this NEET SS Nephrology Recall. Now, this session had to take its own sweet time because we did have a lot of issues in recollecting questions. So once again, at the outset, let me tell you that these questions may be 100% right, may not be 100% right also. So that's something that you have to take with. As far as the students who've been preparing eagerly for nephrology are concerned, a few of them have been able to get through because yesterday night the results for NEET were announced after the interview. And for the others, there is no time to pause and ponder, just have to get on with the game because NEET SS is on the way. It's just about 10 or 15 days away from NEET SS exam, where you really have a very, very strong chance in comparison to NEET where the number of seats are on the lesser side. So, as far as nephrology is concerned, NEET was a pretty tough paper. It was by no means easy. Some of the other subjects were relatively easy. This was by no means easy, as you expect with AIIMS. And olden times we had this AIIMS, PGI, and GPMER, and all the three exams used to be terribly hard. As most of the aspirants have been following videos, especially with FIHALI, majority of the questions you can answer out of it, but then few questions are terribly difficult, which are of course above that level. Let's try to dissect out the questions and see. Especially this is for students who are preparing hard for the NEET SS exam, which is about to happen in a few days' time. So for them, these areas might be of great value because again, we are having a 60-40 distribution for this NEET. This will be the last of the NEET exams with that kind of a distribution. So there it would come in handy to know what are the core zones in nephrology from where they have asked questions in SS. And I think that's going to be pretty similar as far as NEET is also concerned, and we'll just try to get into those zones, and it's very important for you to revise those zones also before we go for the original exam. So that's about it. So once again, ISN, Indian Chapter, Indian Society of Nephrology, KDIGO. These are all the bodies who have governed this over the years, and I think for the NESS interviews, often you get this question, and this is basically Brussels. It's not from where the shoot is happening. Shoot is happening from Bangalore. I would have loved to see the shoot happening from Brussels. Brussels is the capital of Belgium. Belgium, of course, the great historical place. Cockpit of Europe is what Belgium is called. And you remember Belgium for the European battles that have happened over the years, where Belgium has been the center spot. And the famous Waterloo battle, Napoleon, so much of history, I think, in and around Belgium. Have not been fortunate enough to go to Belgium, and with all these variants, I'm not really sure whether I'll be able to go to Belgium at least once. So Brussels is where we have the KDIGO headquarters. And as far as ISN is concerned, Indian Society of Nephrology is celebrating 50 years. It's not 50 years, 51 years now, because it is in 1970 that the Indian Society of Nephrology came into being. And Narayana Prasad sir is currently the secretary of the Indian Society of Nephrology, and he's the HOD of nephrology at Sanjay Gandhi Postgraduate Institute in Lucknow. And of course, KDIGO guidelines are what we have been using mostly. International Society of Nephrology is also based at Brussels in Belgium. So Belgium is becoming very popular. Now, Belgium is popular for a lot of reasons. In hockey also, you can see Belgium, they are the world champions in hockey. And we've had very close contests with Belgium in the Olympics as well as in the World Championships. So I think most of you may be aware. And its position wise also, it's at a very high altitude in comparison to some of the other European countries. So on that note, let us start off with the questions. This was the 2021 World Kidney Day theme, that was living well with kidney disease, and we've done a 10-minute program on what it meant, etc. etc. Upcoming 2022, this is going to be the World Kidney Day theme, that is to bridge the knowledge gap for better kidney care. So what ISN has actually come up with is this whole point that we have a stubbornly high knowledge gap at each level of care. This is ISN's own statement. Stubbornly high knowledge gap at each level of care. That means there is so much of gap to bridge over here. And it is a responsibility of every single nephrology person, everybody concerned with this subject, to actually bridge this gap so that we can offer better levels of care. So that is essentially what ISN wants, and that's essentially what ISN stands for. So this is also something which I would want everybody to know. Nephrology is that one kind of a subject where I think, again, these demands for individual subjects keep changing, because 5 years before, when you look at that point when I was writing the entrance exam, nephrology was the most hottest of the specialties, like now how endocrine is. Endocrine is something which is now sought for by so many students. In comparison, the competitors for nephrology have come down, I think primarily because of the feedback that you get from your seniors. So the feedback is that this is terribly tough. Those 3 years are going to be very hard. had to work. It's like you're working day in and day out, day in. I don't think it's like that for every center. From center to center, it does change. But nephrology is not that easy a subject because it's now gone into more of a procedure-based mode. So when it goes into procedure-based mode, skills also come in very handy. It's a subject where there are a lot of emergencies. It again depends on the level at which you work. So if you're working at the transplant center, again, responsibilities are on the higher side. So it's a different kind of subject, unlike I think endo, rheumatology, etc., which are high on demand these days because they are more easy. That's the simple reason, and they more I guess kind of office work kind of type. So anyway, so for those who are actually interested and made up their mind that nephrology is the way forward, we'll just start off with the questions. Now, this has been the distribution for nephrology questions for NEET SS. I've collected all the 50 questions, I believe, all the 50 questions that were asked in nephrology. A few of the nephrology questions have come under medicine that we'll do as a separate session. So medicine, we have 30 questions. So inside those 30 also, we had 3-4 questions coming from nephrology. Those are very easy for the people who are preparing nephrology, like the use of furosemide in sepsis and AKI, or generally the use of furosemide in AKI. And we've discussed very clearly that as of now, furosemide has no role in AKI. So that was one question. Then certain measures to assess the intravascular volume, including your leg raising test and your ultrasound. So those were two, 3 questions that you did get from nephrology. We'll see that later on. But if you look into core nephrology, relative distribution, let us see. I've told you all the time now. Every time I've kept on repeating this. For any exam in the country, whether it be an undergraduate exam or a postgraduate exam, always the emphasis has been on glomerulus. From time immemorial, it has been like that, which is that single most important topic in nephrology. You don't even have to think twice. It's always going to be glomerulus. And that is why glomerulus has 5 questions. And from the single small chapter inside glomerulus called rare glomerular diseases, you have 3 questions. So 5 plus 3 total, we had 8 questions from glomerulus. So 8 questions from glomerulus is a pretty big number. Out of 50 questions, 8 questions coming from glomerulus means almost like 20% of the questions are from that single unit. So obviously we need to know everything about glomerulus. There is nothing that we can skip as far as glomerulus is concerned. And we have 8 questions. We'll be discussing that. Then of course, transplant. Any SS exam or any kind of an exam with respect to nephrology, questions on transplant are going to be definitely there. And this time around also the questions on transplant were very simple. They always focus on certain areas. Like you have a question on drugs, you have a question on rejection, you have a question on recurrence post-transplant. So that's how it is. Pregnancy, 3 questions. Pregnancy is one chapter that you have to be studying thoroughly because 100% you will get questions from pregnancy, and the area, the zone is actually very less. You have just 3 headings in pregnancy to study. Normal physiological changes during pregnancy, you get 1 single question. Another question will be on this AKI in pregnancy, which is a comparison between HUS and TTP, and of course AFLP and preeclampsia. Then you have another question which is primarily going to be on a person with lupus getting pregnant or somebody with another glomerular disease getting pregnant. So that's how the questions are generally, and we have 3 questions. Nephrorheumatology crosstalk is something that's very interesting. Every time we have a question on rheumatological disease with a nephrology manifestation, rheumatological disease with a renal manifestation, we have a question. This time also we get 4 questions. Hereditary cystic diseases of the kidney are mostly going to be based on ADPKD. We had 3 questions from there. Vascular questions were tough this time. There were 3 questions which were more or less based on TMA and RAS. They were tough questions. AKI was just 3 questions. 6 questions based on metabolism. Metabolism is another major chapter where you have this hyperkalemia, hyperphosphatemia, RTAs and all that, which we've discussed in detail. General nephrology, 2 questions that is based on your GFR and stuff. CKD had a very, very low representation. Dialysis, 4 questions, of which 3 were from hemodialysis, just 1 question from peritoneal dialysis. Nephrology, urology is something which I don't like because these 3 questions were proper urology questions. It's tough for a nephrology student to answer them. And this is something which we didn't teach also because I didn't go into the urological areas. I didn't teach them stones, etc. So this was harsh. And pediatric nephrology, we had this 1 sole question. So this was how the distribution was. And the distribution, I think, was pretty much keeping in pace with what NEET is generally. And out of the distribution, what I want you to keep in mind for the few days coming up before the exam, to have a thorough reading on glomerular diseases, especially on the single chapter called rare glomerular diseases, where we do get a lot of questions these days. To have a thorough reading on pregnancy, 3 chapters. To have a thorough reading on ADPKD. To have a thorough reading on rejection and drugs used in transplant. To have a very thorough reading on this basic metabolism chapter, including hyperkalemia, RTA, hyperphosphatemia, hypercalcemia, and that stuff. And of course, few other chapters which I'll mention on the way that we are going to be discussing. So let's start off with the question. So the first of the unit that I have actually taken up is this small chapter called rare glomerular diseases. And inside this rare glomerular diseases, we had 3 questions. All the 3 questions were tough questions. We'll just see through those 3 questions. Question number 1 was on nodular glomerulosclerosis. All the following are causes of nodular glomerulosclerosis except diabetic nephropathy, MIDD, smoking, collagen type 3 glomerulopathy. This was one question. Second question was on DNA JB9, which is a novel marker for which of the following glomerular diseases. And the third question was correct matching, all except Wheel syndrome, rhabdoreticularis, cloudy cornea, LCAT deficiency, paresthesia, Fabry's disease, facial hyperdystrophy, and MPGN. So these are the 3 questions that we have from this chapter called rare glomerular diseases. In this chapter called rare glomerular diseases, we have tried to cover. There are quite a lot of rare glomerular diseases. It is not practical to cover everything. I have discussed in detail amyloidosis. Then I have gone and discussed fibrillary immunotactic glomerulonephritis, which is basically a comparison question. Then we have gone and discussed a few words about type 3 collagen glomerulopathy or fibronectin glomerulopathy. We have also discussed 1 or 2 words about Fabry. We have discussed 1 or 2 words about LCAT. And that's how we have summed up the chapter. And I think all of you have seen that module. It's about a 20-minute module where I've just tried to brush through the most important points. Let's see whether we've been able to answer the questions. Question number 1 is on causes of nodular glomerulosclerosis except nodules in the kidney, nodules in the glomeruli, nodules in the mesangium are something which we have discussed out and out. We've been using this term again and again, but unfortunately with that we cannot answer this question. So let's see. So whenever I talk about nodules, like for that matter, whenever a nephrologist talks about nodule, we always start with Kimmel-Steen-Wilson nodule, so diabetic nephropathy. So obviously we ask you this question, what are the other causes of nodules in the kidney? That's an MBBS level question. Then at the MBBS level, we say MPGN is another cause for nodules. So everything that comes under MPGN can have nodules. So that's it. So at the MBBS level, you probably know the 2 conditions producing nodules are diabetic nephropathy and MPGN. Then as you go to a MD level, then you start thinking about a few more other causes for nodules. And as we go to this entrance preparation level, obviously I myself have kept on repeating that monoclonal immunoglobulin deposition disease, or what we call this light chain deposition disease, is a very, very important cause. Amyloidosis is a very important cause. Amyloidosis produces nodules. LCDD produces nodules. So if you look into the class and if you read any standard textbook, I think everybody would be knowing that diabetic nephropathy is a very important cause for nodules. MPGN is a very important cause for nodules. Monoclonal immunoglobulin deposition disease or light chain deposition disease, which is pretty much a kappa deposition disease, is something where you get nodules. AL amyloidosis, which is basically a lambda deposition disease, again you get nodules. So these are 4 things which everybody knows. So amyloidosis we get nodule, MIDD we get nodule, MPGN we get nodule, diabetic nephropathy we get nodule. So on the basis of that, students thought like, okay, diabetic nephropathy definitely nodules, MIDD definitely nodules. So the question was, or the doubt was, whether it's smoking or collagen type 3 glomerulopathy. So I have told you very clearly in class that MPGN is just a pattern for exploration. It is not a disease. And I think I have repeated that so many times. MPGN is not a disease. MPGN is just a pattern for exploration. You just look at a pattern and you decide on what is to be done. You need to find out a diagnosis. So once you get the MPGN pattern, you see whether it is an immune complex deposit predominant pattern or it is a C3 predominant pattern. Once it is a C3 predominant pattern, then you start going into C3 glomerulopathy and your C3GN and dense deposit disease that we have discussed. If it is an immune complex predominant pattern, then you actually see whether it is a polyclonal pattern or whether it is a monoclonal pattern. So this is very important to know. Polyclonal patterns again have so many causes, but one striking important cause that comes to mind is hepatitis C virus. Once you know that it is a monoclonal pattern, then this monoclonal pattern actually needs to be discussed in a bit more detail. Monoclonal pattern, you can again think about it in so many ways. One way to think about it is whether it is congruent positive or whether it is congruent negative, because once it is congruent positive and then you are having this lambda restriction, then it becomes very clear that it is amyloidosis. Suppose it is a congruent negative, then mostly we are going to think about immunotactic glomerulonephritis, which is mostly monoclonal, and of course most importantly this monoclonal immunoglobulin deposition disease, MIDD. This is another way you can look at it. Or you can also think about monoclonal as organized deposits and non-organized deposits, which we have again discussed, where this non-organized deposits I have told you, comes mostly under monoclonal immunoglobulin deposition disease. Organized deposits can be divided into fibrils and can be divided into tubules. Under fibrils, you have AL amyloidosis and fibrillary glomerulonephritis. Under tubules, you have immunotactic glomerulonephritis. So this is also something that we have studied. And we'll again come back to that. So many ways we have actually tried to see the pattern approach to this disease called MPGN. And I told you everything can present as MPGN, including all those rare diseases under that chapter. So everybody was under the impression that collagen type 3 glomerulopathy is a rare disease which comes under MPGN. So probably that can also be the answer. And I think most of the people mark this as smoking. So let us see what this question actually stands for. Let me tell you that this question is a wrong question, okay? Because all these 4 options can actually produce nodules. Smoking is also a cause for nodules in the kidney. Collagen type 3 glomerulopathy can also produce nodules. Diabetes can produce nodules. MIDD can produce nodules. So this is a question. We are starting upfront with the question is really does not make sense. Let's just try to look through some of these tables. So the moment you are having nodules in the kidney, you can see this. Diabetic nephropathy is the first cause. Smoking associated nodular glomerulosclerosis, you can see there is an entity as such like that. Membranoproliferative glomerulonephritis, everything. Glomerulopathies with fibrillar deposits, congruent positive, that is amyloidosis, congruent negative, fibrillary glomerulonephritis, immunotactic glomerulonephritis, light chain deposition disease, fibronectin glomerulopathy, collagenofibrotic glomerulopathy. So that's it. Okay, so all these are actually speaking right answers. Now, this is the table that I showed in class. And in this particular table, you can actually see that monoclonal immunofluorescence negative with nodules. I have told you diabetes. I didn't mention the smoking. Okay, and then this is now there. The smoking is also there. Immunofluorescence positive, monoclonal, paraprotein related. Most important is your amyloid. Polyclonal. Immunotactic is generally monoclonal. Fibrillary is the one that is generally polyclonal. So fibrillary is the one that is generally polyclonal. Okay, so many entities are actually there inside this, which is pretty difficult to actually study. Let us try to look at it once more before we go, because again, this is a question that can come for the exam. So we just look into this once more and then we'll again come back. So when you get a question like this for the exam, obviously we are going to get confused. And as you can see over here, this question really does not have a single answer. Let me just try to make it very simple. Causes for nodules in the kidney. Causes for nodules in the kidney are diabetic nephropathy, MPGN pattern, monoclonal immunoglobulin deposition disease, AL amyloidosis. These are the 4 top causes. Under MPGN patterns can be polyclonal patterns, monoclonal patterns. First, immune complex deposition pattern or C3 predominant pattern. Under immune complex deposition pattern, polyclonal pattern, monoclonal pattern. Polyclonal patterns, mostly think about HCV. HCV is the most important cause. Fibrillary also generally has a polyclonal pattern. Fibrillary glomerulonephritis will come to is generally having a polyclonal pattern. Under this monoclonal pattern, you have congruent positive, that is amyloidosis. That is the most important thing. Suppose it is congruent negative, you think more about immunotactic glomerulonephritis and monoclonal immunoglobulin deposition disease. And rarely on this type 3 collagen glomerulopathy. Okay, and now we have seen one more cause, that is smoking. So that's the only way that we can study this. These are the causes. Another way of classifying is you can look into organized or non-organized deposits. Under organized deposits, I told you it can be fibrils or tubules. Fibrils can be amyloidosis and your fibrillary glomerulonephritis, and the diameter of the fibrils we will see. With that, we discuss as to how to differentiate. Tubules can be cryo or immunodactoid. Okay, cryo or immunodactoid. And non-organized, only one cause to study, that is monoclonal immunoglobulin deposition disease, or what we call light chain deposition disease. And then there is another entity called PGN MIDD, which I told you is not required at our level. That is proliferative glomerulonephritis with monoclonal immunoglobulin deposition disease. So PGN MIDD is not at our level. So these are the things that I expect you to know. Now, before we discuss further on this, we go to the second question. Second question has a definite answer. DNA JB9 is a novel marker of, and this is something that we have discussed in class. I'll show you the slides. DNA JB9 is a novel marker of fibrillary glomerulopathy. So when going into the next level discussion, I have tried to actually mention what is the difference between fibrillary and immunotactic glomerulonephritis. Okay, so fibrillary and immunotactic glomerulonephritis, how do you actually come to this thought process? What is this? Both are actually characterized by fibrillary or microtubular deposits in the mesangium and the capillary wall. So fibrillary and microtubular deposits in the mesangium capillary wall, they are non-amyloid, they are congruent negative. Non-amyloid congruent negative. Most important point is the thickness of the fibril. And that's where I told you this question has been asked so many times for the exam. Amyloidosis, you have fibrils which are 8 to 15 nanometer in thickness. Fibrillary glomerulopathy, you have again got fibrils which are 12 to 22 nanometers in thickness. 12 to 22 nanometers in thickness. Immunotactoid, instead of fibrils, you are having microtubules which are more than 30 nanometers in thickness. This is a very, very important question. So I told you again up front that we can divide this monoclonal into organized and non-organized. Organized can be divided into fibrils and tubules. Fibrils, you see amyloidosis, and then that is 8 to 15. 15 to 12 to 22, you have fibrillary glomerulonephritis. Fibrillary glomerulonephritis is generally polyclonal. More than monoclonal, it's generally polyclonal. Immunotactoid is generally monoclonal. It is associated with CLL, etc. There, the thickness of the tubule there, not fibril, thickness of the tubule is more than 30 nanometers. So this 8 to 15, 12 to 22, and more than 30 are actually very, very, very important. Okay, and you can see that amyloidosis is mostly monoclonal, that is lambda. Immunotactoid is usually monoclonal, yes, can be kappa or lambda like that, and fibrillary is usually polyclonal. Yes, fibrillary is usually polyclonal. That's why this is a very, very important question. Correct. So all these things we have actually seen. And light chain deposition disease is something that is having non-organized deposits. So that's completely different. This is organized deposits. Organized deposits congruent positive, amyloidosis. Organized deposits congruent negative is actually fibrillary immunotactoid. Difference between fibrillary and immunotactoid mostly based on the thickness. One is fibril, another one is actually speaking tubule. One is actually having a very low diameter, that's around 12 to 22 nanometers. The other one is more than 30 nanometers. This we have actually seen. Now, immunotactoid is often monoclonal related to CLL Waldenstrom's. This is the next point. This also I made very clear in my class. Now, the next thing that we discussed was the fact that both have a similar clinical picture. There I told you certain important points of difference. The first point of difference was MPGN kind of a presentation was more common with fibrillary. Membranous more than MPGN kind of a presentation was more common with immunotactoid. So both had actually kind of a nephrotic range proteinuria with microhematuria kind of a presentation, but nephrotic picture was more common in fibrillary. That's why MPGN presentation was more common. Nephrotic picture was more common in immunotactoid. That's why membranous is more common. So that's the next question. Then IgG4 in the mesangium. IgG4 containing deposits in the mesangium. So it can be polyclonal most of the time. Fibrils are 12 to 22 nanometers. Here large thick-walled tubules more than 30 nanometers, monoclonal. And here you can see DNA JB9. The same question came for the exam. DNA JB9 is a marker of fibrillary. And treatment part I told you is very confusing. There is actually nothing much of data on that. We generally treat fibrillary with steroids and rituximab. 50% goes to ESRD. Better response on treatment for malignancy for immunotactoid. So this is what we discussed. So essentially what I wanted to remember for the exam are these key points. One, that immunotactoid is more monoclonal than polyclonal. Immunotactoid has more membranous presentation than MPGN presentation. Immunotactoid is tubule. The other one is fibril. Immunotactoid is more than 30 nanometers. The other one is actually 12 to 22 nanometers. And you can also see 1-2 other points. Pulmonary hemorrhage is generally described with fibrillary glomerulonephritis. So pulmonary hemorrhage is described. Renal presentation I told you for fibrillary is more of MPGN pattern. For your immunotactoid is more of membranous pattern. Immunotactoid is about treating the monoclonal disease, that is your CLL. Fibrillary can be treated with steroid and rituximab. 50% actually go to ESRD. Okay, so that is what we studied, and it is from this same question, this same pool, that we have this question, and this is the second of the questions that we're discussing, DNA JB9. And DNA JB9 is something about which I have not discussed in great detail. Even we are not aware of much details, but this is an upcoming question, and that's why there has been again asked for the exam. You can see DNA JB9 serum levels are elevated in fibrillary glomerulonephritis. This is again from Eyes and Kidney International. And you can see serum levels of DNA JB9 could be a valuable marker to predict fibrillary glomerulonephritis. If you ask me more about this, very sorry, I also do not have much of an idea. It is something that we are actually seeing. And fibrillary glomerulonephritis, I told you, it can be monoclonal, can be polyclonal most of the time. Sometimes it can be monoclonal also. Okay, right. But I think most of the students would have answered this primarily because one reason that it is there in FIHALI. So it's mentioned in FIHALI, and of course we've discussed that also. So that's about DNA JB9. Third of the questions is with respect to correctly matched or all except. Wheel syndrome and libido reticularis, cloudy cornea and LCAT deficiency, paresthesia Anderson-Fabry, facial lipodystrophy, MPGN. Now, this is something which we have straight to discuss. I told you the only thing that you need to remember about LCAT deficiency is about your fish eye and your eye problems and corneal clouding. So that is a straight answer. Fabry is characterized by angiokeratoma, acroparesthesia. I think even without learning nephrology, you know that we discuss Fabry alongside with inherited diseases. MPGN type 2 or the current C3GN is typically associated with only two conditions, optic nerve drusen and facial lipodystrophy. That again we have discussed. Wheel syndrome, all of you know, is your hepatorenal damage in leptospirosis. That and livedoreticularis has got nothing to do with each other. So this particular question, the answer is Wheel syndrome and livedoreticularis. It's a very straightforward question. So 3 questions on rare glomerular diseases, but obviously remember that these 3 questions are not very easy, and one of them is actually still kind of nowhere with respect to the answer. So these are the 3 questions that we had. I think second question and third question everybody would have answered. First questions really does not have an answer. So that's about it. Now inside this, always I'm telling you, please don't forget to go and look into LCDD once again. LCDD is your monoclonal immunoglobulin deposition disease. Monoclonal immunoglobulin deposition disease is also a very important topic. I told you we can look at it from so many ways and from so many angles. Monoclonal immunoglobulin deposition disease is an example for a monoclonal pattern, okay, where you are having non-organized deposits. So monoclonal pattern, non-organized deposits. The moment you are having a monoclonal pattern, non-organized deposits, we think about monoclonal immunoglobulin deposition disease, inside which we think of light chain deposition disease. Okay, monoclonal immunoglobulin deposition disease, we think of light chain deposition disease. That's why you can actually call it as non-amyloid. It is non-amyloid because it is congruent negative. It is non-fibrillar. Yes, because it is non-organized. So non-amyloid, it is non-fibrillar, and it's actually characterized by nodules. So non-amyloid, non-fibrillar, nodules. And the moment you see LCDD, always what has to come to mind? Kappa has to come to mind. Amyloid, what has to come to mind? Lambda has to come to mind. And also very important to keep in mind that 60% of patients have associated myeloma. When you look at AL amyloidosis, only 10% of the people have associated myeloma. Here 60% are having associated myeloma, and it is the second most common glomerular manifestation of a plasma cell dyscrasia. Most common glomerular manifestation of a plasma cell dyscrasia is AL amyloidosis. Second most common glomerular manifestation is actually monoclonal immunoglobulin deposition disease. Proteinuria and rapid progression to CKD. Liver and cardiac deposits also seen. PS positive nodules in the mesangium with mild cellularity, and they are congruent negative. Okay, and poorly argyrophilic. Now this is important to understand, and this is also a very important question. We'll come back to it. Anti-kappa beta seen. Yes, anti-kappa seen. Nephrotic syndrome or rapidly progressive tubular interstitial dysfunction with diastolic dysfunction again. That's also been asked for the exam. Okay, so that's about this. So please go back and learn this part also. Monoclonal immunoglobulin deposition disease is also very important. So finally, before we actually wind this up, I just want you to keep this in mind. Amyloidosis can have nodules. Yes, fibrillary glomerulonephritis can have nodules. Collagen or fibrotic glomerulopathy and fibronectin glomerulopathy can also actually have nodules. And we haven't discussed so much about that. I just told you that it is a variant of your nail patella syndrome. So the findings are pretty similar to that. And also that it presents with a membranous kind of a presentation with more of nephrotic syndrome. We really don't have much idea into that. Mesangial proliferation, more than proliferation, hypercellularity will be seen with nodules. And then, of course, collagen type 3 will be seen on electron microscope. This is what we know. And hardly 40-45 cases have been reported and nodules are there. So you can see collagen glomerulopathy, idiopathic nodular glomerulosclerosis, monoclonal immunoglobulin deposition disease, diabetic nephropathy, fibrillary glomerulonephritis. So when you look at it from an exam perspective, diabetes is very important. Immunotactic is very important. Fibrillary glomerulonephritis is important. Monoclonal immunoglobulin deposition disease is important. So I just tell you a few points which are very crucial here. Almost everything is actually speaking PAS positive. Okay, almost everything actually speaking is PAS positive. Only thing that you have to remember for your exam is amyloid and collagen glomerulopathy. Okay, amyloid and collagen are the only things which are PAS negative. So only things which are PAS negative are amyloid and collagen glomerulopathy. You can even say amyloid is, weakly PAS positive according to some books, but like as per this KI article, it's PAS negative. So amyloid and collagen are the only things which are PAS negative. Everything else you can see is PAS positive. Then this is a question that has been asked for your exam. Everything is silver negative. Only two things are actually silver positive, of which only you need to know diabetes. Idiopathic nodular glomerulosclerosis is also speaking silver positive, but you need to know only this. Mason's trichrome, everything is blue. Only thing that is red in Mason's trichrome is fibronectin glomerulopathy. So fibronectin glomerulopathy is the only thing that is red under Mason's trichrome. And of course, everything is congruent negative. Only thing that is congruent positive is your amyloidosis. So that's why we describe amyloidosis as extracellular fibrillary deposits, which are actually your 7.5 to 10 nanometer deposits, which are of indefinite length, which are characterized by congruent positivity, mostly lambda restriction, which is blue under the Mason's trichrome, which is silver negative, and which is PS negative or weakly PS positive. Okay, so these are the other questions. So please don't miss out on this. 100% sure to get a question on rare glomerular diseases for your NEET SS also. So these are the 3 questions that have come from this, and I think mostly we've been able to tackle them. Unfortunately, this question does not have an answer. So that's the end of the first discussion, and the first discussion was on rare glomerular diseases. From rare glomerular diseases, we move to our topic number 2. So this is just to show you lipid thrombi with ApoE deposits is what we actually see with psoriasis and even with TMA. LCAT deficiency, fisheye, autosomal recessive disease with prominent renal manifestations similar to LMX1B. LMX1B was your nail patella. This is your collagenofibrotic glomerulopathy. Okay, collagenofibrotic glomerulopathy. So all this you've seen. Then Fabry we've discussed alongside with Alport and nail patella. X-linked neutral glycosphingolipid accumulation due to defect in enzyme called alpha galactosidase A. We've seen about angiokeratomas, acroparesthesias, few other heart manifestations, renal manifestations extra in detail. Angiokeratomas, you can see painful acroparesthesias, you can see this has come for the exam. This very same photo I told you, this is to show you partial lipodystrophy. Optic nerve drusen and partial lipodystrophy are the only 2 manifestations that you need to remember with respect to C3 glomerular diseases, C3 glomerulonephritis and dense deposit disease and all that we have discussed. This is to show you a patient with LCAT deficiency who has cloudy cornea. So that's about that discussion, and this DNA JB9 which you see with fibrillary. So this might actually seem little Greek and Latin for people who are not into core nephrology, because this is a very irritating part of nephrology, I would say, because we don't see these cases very often. I mean, 3-year nephrology course you may see one single case of a fibrillary or fibrillary or immunotactoid, but for the entrance exam, especially for your NESET and even for your NEET, these are like areas from where you will definitely get 1 or 2 questions. So then we've tried to discuss them in detail. So please try to study it from the angle of an MPGN person. That means you look at MPGN not as a disease, look at MPGN as a pattern for exploration. See the MPGN module thoroughly, see how we approach MPGN at each levels, at a LM level, at a IF level, at a electron microscopy level, and see what are the DDs, how we look into each of the DDs, how important is electron microscopy, how we differentiate each of these things based on whether they are fibrils or tubules, the thickness, etc., and finally have a pattern in mind. Like for example, when I think of MPGN, I have C3 immune complex poly mono, poly HCV cryo. Mono, again I think of congruent positive, congruent negative. Congruent positive, I think of amyloid. Congruent negative with monoclonality maintained, I think of MIDD. I think of immunotactoid. So that's, I think, pretty okay. Organized deposits, non-organized deposits. Non-organized deposits, I think of MIDD. Non-organized deposits, fibril tubule. Tubule, we think of cryo. Tubule, we think of immunotactoid. Fibril, we think of amyloid. We think of fibrillary. Okay, so that's about the first unit. We go to the second of the units, from where you have 3 questions. Hereditary cystic diseases of the kidney. So hereditary cystic disease of the kidney is a short chapter where we discussed ADPKD, ARPKD, nephronophthisis, medullary cystic disease of kidney, which I now told you is called as autosomal dominant tubular interstitial kidney disease, and so on. So this is that second of the chapters from where we had 3 questions. Let us look at those 3 questions. Extrarenal manifestations of ADPKD are all except was the first question. Option number 1, pericardial effusion. Option number 2, male infertility. Option number 3, female infertility. Option number 4, seminal vesicle cyst. Okay. Second question was PropKD score does not include rate of kidney enlargement, hypertension before 35, hematuria before 35, PKD when truncating mutation. Question number 2. Question number 3 was a teenage boy with a creatinine 3.6 with a normal size kidney on ultrasound with a NPHP1 mutation present. Biopsy expected feature is IFTA only, glomerulomegaly with oligomeganephronia, podocyte loss, tubular base membrane vasculitis. So these are the 3 questions. Let us start looking into questions one by one. Extrarenal manifestations of ADPKD are all except. The moment you think of extrarenal manifestations of ADPKD, obviously this particular slide comes to mind. So we study the most common is hepatic cyst, and you can get cyst everywhere. Then colonic diverticula, sacral aneurysms of the anterior circulation, mitral valve prolapse, aortic regurgitation, aortic root dilatation, from where I also told you that you can have biventricular dysfunction. It's mostly a biventricular diastolic dysfunction that you see, especially with the hypertension that has got a predominant, that has got a disproportionate target organ damage, abdominal wall hernias, inguinal hernias. These are the things which everybody knows. And I think in one of the MCQ discussions, I've made it very clear that cyst can be seen everywhere. Cyst can be seen anywhere except the brain. And one prominent site where we see cyst is seminal vesicle cyst. And I've shown you an image also of that with a male presenting with infertility. In our MCQ questions, you can see that. And that is primarily because I think my teachers, whose teacher was Muthu Sedupati sir, who was primarily the HOD of nephrology 25 years back at Madras Medical College, and he kept on asking this question. So this question is a very popular question in Chennai circles. That is, ADPKD patient having infertility and what is the cause? And then you say seminal vesicle cyst. So male infertility because of seminal vesicle cyst, but female infertility is not produced by ADPKD. It's a dictum statement. And I think the same statement I have also said. Pericardial effusion, to be very frank with you, I had not much idea of whether ADPKD can produce pericardial effusion, but now again we go back and look into the literature and look into some of the textbook data. Of course, Fihari doesn't mention anything about it, but you go to Brenner does mention that pericardial effusion can be seen with ADPKD, but female infertility is never associated with ADPKD, and we have made that very clear. So male infertility, seminal vesicle cyst, of course you can see. Pericardial effusion, yes, it is there. Female infertility is not seen. But even if you don't know pericardial effusion, if you remember the statement that cysts can be seen everywhere, including the seminal vesicles, where we get male infertility, females we don't get infertility, and then the image, if you remember, you'll be able to answer this question. Otherwise, for a beginner, this is a slightly tougher question. But I think this is a question which I consider that I have taught because of the fact that we have mentioned about this. Second question is a question on PropKD score. Now, this is pretty unfortunate because I did not mention this score called PropKD score. This is the slide that we have discussed. The slide that we have discussed was on why only 60% patients develop ESRD by 60 years. I kept on talking about this. And I told you there are certain things which determine who are more likely to develop ESRD. Where I told you black males, diagnosis before 30 years, hematuria before 30 years, hypertension before 35 years, and PKD even truncating mutations. All these things actually come under a score. And that score is what we actually mean by your PropKD scoring system. So you can see here male, hypertension, urological event is hematuria, PKD even non-truncating, PKD even truncating, PKD2 mutation, all these things together. And inside this, these are the ones which are associated with bad prognosis. That is your black male, diagnosis before 30, hematuria before 30, hypertension before 35, PKD even truncating mutation. And I told you also this, that kidney and cyst volume on MRI, although the score does not include this, kidney and cyst volume on MRI are the single most important risk factors. And that is actually unfortunate because I did not mention the score anywhere here. So under the score comes only these many things. Kidney and cyst volume on MRI. After telling you this, I told you that the best investigation to look for your chance of developing renal failure is your MRI. And this MRI is very, very important because kidney volume and cyst volume on MRI are the single most strongest risk factors which will actually tell you this. And I don't know how many of you understood it in that sense. People really got confused on hearing this term called PropKD score, because this PropKD score is something that we have not discussed, and when Fihari does not mention the name of the score called PropKD score. So on suddenly seeing PropKD score, I think people got confused. The answer for this question is rate of kidney enlargement, because under PropKD score comes male sex, early diagnosis before 30, hematuria before 30, hypertension before 35, truncating mutations which obviously have a bad prognosis, PKD and truncating mutations, all that comes under PropKD score. But the single best thing is to always go for MRI, and MRI will actually tell you about the kidney volume, cyst volume. Yes, so I knew this. I could have easily taught you this. It is not something which I did not know, but then I didn't put the name of the score, and because of that it became a little confusing. But if you have listened very carefully, you should be able to pick it up. But that's very sad. Okay, that is question number 2. Question number 3, which came from here, is a very simple question. I think nobody should have any doubt with respect to this question. And that question is on, you don't even have to read this question in total. The moment you see NPHP1 mutation, you know that what we are looking for in NPHP1 mutation. NPHP1 mutation stands for juvenile nephronophthisis. Juvenile nephronophthisis, our opening slide itself on juvenile nephronophthisis was based on this. Tubular basement membrane irregularities, tubular atrophy with cyst formation, interstitial infiltration with fibrosis, autosomal recessive inheritance, NPHP1, nephrocysteine, chromosome 2, cilia centrosome complex. This is how I started the discussion itself. Starts by around 6 to 7 years and then progresses to ESRD by 13 to 14 years. So if you read through this question also, it's like a very simple question, tubular basement membrane irregularity. So that's a very simple, straightforward pick. So the first question was slightly tough, but still we have mentioned that very clearly. Third question is very easy. Second question is a tough question because if you don't know what is PropKD score, then you are likely to be a little confused. Okay, so that is what it is. Now, cyst hemorrhage and hematuria, cyst infection, cyst rupture are the three major complications to be kept in mind. Uric acid stones are the most common stones. Biventricular diastolic dysfunction we can mention. FDG PET for infections and CT orography for stones. So that's it. Right, and actually speaking, for a DM student, this is a very simple question because we have this famous study called CRISP study. Okay, we get this question every time for our DM Viva. So CRISP study is for ADPKD. So the full form of CRISP, it's some of the examiners ask, is a Consortium for Renal Imaging in Studies with Polycystic Kidney Disease. This CRISP is based on MRI. And that is the strongest predictor. But unfortunately, this MRI-based prediction, that is based on kidney volume and cyst volume, is not included in what? It's not included in this PROP-KD. So that's why I have discussed both as separate things. But I think many of the students were not able to pick it up. So that's what NEET SS is about. So that brings us to the end of the second thing. So this is again to tell you seminal vesicle cyst. Points on juvenile nephronophthisis, just kind of repetition. Juvenile nephronophthisis presents at around 4 to 6 years. How does it present? With basic tubular interstitial pattern, salt wasting polyuria, failure to thrive, rapid progression to CTID, ESRD by 13 years. Tubular interstitial diseases do not recur in transplant kidney. The other manifestations have all been asked for the exam, and I've told you what each one stands for. Senior Loken syndrome with retinitis pigmentosa, oculomotor apraxia, that is Cogan, cerebellar aplasia, that is Joubert, and situs inversus. How to compare and contrast this with abnormalities in Alport and all we have discussed in detail. Now, alongside with this, I told you we have to always keep in mind an entity called medullary cystic disease of kidney, which is now called autosomal dominant tubular kidney disease, or ADTK. Autosomal dominant tubular interstitial kidney disease also is okay. Now, how you differentiate between the two is a very important entrance question. I told you that your juvenile nephronophthisis is autosomal recessive disease. This is autosomal dominant. Chromosome 2 for nephrocystin NPHP1 there. Here you are having two chromosomes, 1 and 16, of which MCKD2 chromosome 16 is very important because a protein has been identified, that is uromodulin. That is seen in children. This is seen in young adults. Symptoms are very similar, but their rickets will be seen because here growth is completed, rickets won't be seen. There you had this retinitis pigmentosa and cerebellar aplasia and all those things. Here you are having hyperuricemia, gout, and insulin resistance. Okay, hyperuricemia, gout, and insulin resistance. It's very, very important to know this and this classification also. Okay, ADPKD, ARPKD, NPHP, what are the differences between each of the things? Everything we have actually discussed. Please do keep in mind CNS aneurysms, liver cyst, nephrocalcinosis, high BP, cyst infection. All these things are part and parcel of ADPKD. And I've also told you in pediatrics to please go back and learn on the differences between tuberous sclerosis producing cyst versus von Hippel-Lindau producing cyst. Tuberous sclerosis produces big multiple cysts, where the most common manifestation is not cyst, it is angiomyolipoma. Von Hippel-Lindau produces few cysts, small cysts, where the most important manifestation is liver and pancreatic cyst. Where the most important manifestation is pancreatic cyst more than your kidney cyst. And there in VHL, it's all about RCC. Okay, that is the most common manifestation. Whereas in tuberous sclerosis, it's all about angiomyolipoma. But which is the condition where cysts are prominent means it is always tuberous sclerosis where cysts are prominent. So that's a very small chapter, but please go back and see the chapter. Very likely to get questions from there. Yes, we go to core glomerulus, 5 questions. Core glomerulus 5 questions are actually speaking very, very easy. Let us start off with this. 25-year-old IV drug abuser developing edema ascites, hepatitis C positive. So the question is hepatitis C positive. Urine analysis showing proteinuria, hematuria. So HCV patient having a glomerular disease. HCV patient having a glomerular disease, which of the following is least likely is the question. When a HCV patient has a glomerular disease and you are doing biopsy for a HCV patient with a glomerular disease, you are mostly expecting to see what? Membranoproliferative glomerulonephritis. And not just membranoproliferative glomerulonephritis, cryoglobulinemia is like part and parcel of HCV. Extra hepatic manifestations of HCV means straight away what comes to mind? Cryo comes to mind, Sjogren comes to mind, porphyria data comes to mind, lichen planus comes to mind, MPGN comes to mind. So naturally they all go hand in hand. So cryo, MPGN are two things which are very easy. There is absolutely no doubt. Membranous nephropathy is most commonly associated with HBV. Then only it is HCV. So there it is HBV, then HCV. So membranous can also be put as right. Mixed cryo is obviously right. Which is not possible or least likely possible is the question. Now in this question you have to be very, very clear. FSGS, I'll show you the table on FSGS. FSGS, if you see, I'll show you FSGS. If you look into the causes for FSGS, there are so many viral infections that have been described along with FSGS, but nobody mentions anywhere that FSGS is associated with what? Hepatitis C. You can see HIV here, you can see parvo here, you can see simian virus 40, you can see cytomegalovirus. So if you look at it that way, hepatitis C and FSGS, there is absolutely no association. So many people mark the answer as FSGS, but I'm telling you that is wrong. Rarely FSGS may be associated with hepatitis C. So no, that's not the answer. The answer is definitely polyarteritis nodosa. They are just trying to check out whether you know this one simple thing in polyarteritis nodosa, which I have mentioned hundreds of times. Polyarteritis nodosa is a disease. It is a medium vessel immune complex vasculitis, pure medium vessel immune complex vasculitis, which does not involve the parenchyma of two organs. It does not involve the parenchyma of the lung. It does not involve the parenchyma of the kidney, which means that diffuse alveolar hemorrhage, pulmonary hemorrhage, etc. cannot be seen there. At the same time, glomerulonephritis, glomerular diseases cannot be seen there. PAN is a disease which does not involve the glomerulus. PAN involves the kidney, means it is a vascular involvement. It can produce aneurysms, microaneurysms in the vasculature, and thus it can present with a renal artery stenosis. PAN per se will never involve the kidney. I mean, kidney, glomerulus or tubular incision. The parenchyma structure of the kidney will not be touched. So because of which, whatever said and done, this question has only one answer, and that is PAN. They're just trying to check out on this, whether you know that PAN does not involve the kidney. If you know that PAN does not involve the kidney, and this is a simple answer. Okay, otherwise you can still have a confusion as to from where does FSGS come here. FSGS, I think I told you again and again, FSGS means 4 viruses, HIV most important, Parvo-B19 second most important, EBV, CMV. I've kept on repeating this. So many people like kind of have this impression in their mind that, okay, anyway, we don't have this alongside with FSGS, so let us mark it as FSGS and come out. In a normal question, this would have been an answer, but in a NEET SS question, which is a higher order question, I think the examiner is looking out for whether you know whether PAN is involved with respect to hepatitis C, or whether you are having PAN involving the kidney, etc., etc. First and foremost, PAN is associated with hepatitis B, where I told you this very important rule called 31 rule. 30% patients with PAN are hepatitis B positive, but only 1% of patients with hepatitis B positivity have PAN. So that is one thing that you can actually use to eliminate here. Another point is that PAN does not involve the substance or the parenchyma or the glomerulus or the interstitium of the kidney. That is this. So I don't consider this as a very tough question, although these two options can be confusing, but I think it's pretty okay. False regarding anti-Gbm disease. This is a tough question. Okay, this I would definitely mark as a tough question. What is false regarding anti-Gbm disease? Now, anti-Gbm disease we have discussed in detail. Okay, in great detail we have discussed anti-Gbm disease. Almost everything about anti-Gbm disease, head to foot, we have discussed. And if you have watched the discussion properly, you'll be able to come out with the answer on reading the first statement, although you may not understand much on the others. Pulmonary hemorrhage is more in young females. No, we have discussed this very clearly. At the outset itself, I told you, there is only one glomerular disease where you have to keep smoking in mind, that is anti-Gbm. Young male smoker coming with pulmonary alveolar hemorrhage, young male smoker coming with moderate to massive hemoptysis. Always think of it. I showed you the X-ray and all the other things. So pulmonary hemorrhage is definitely more in young males, and it is in young male smokers. So obviously this answer is wrong. So if you know that, you cannot, you can actually skip reading the other options and you can confidently mark it as the answer and come out. That is the correct answer also. But if you want to know more in detail about the other options, then it becomes a little tough. I have never used this word called Hammersmith regime. To be very frank with you, I also did not know that this regime is called Hammersmith regime. The regime that we keep on using, this is the regime that we are using for good pasture. And I myself found it very difficult to find out that this name is actually Hammersmith regime. And I came to know it only a few days back while searching out for this. The regime that we used is plasma exchange with steroid cyclophosphamide, and this is a regime that actually came in 1970, and this is conceptualized, this is actually revolutionized everything, and the treatment protocol was used at Hammersmith Hospital. So this protocol was used at Hammersmith Hospital. So probably I think the name of the regime is Hammersmith regime. That is what I presume. I don't know how many nephrologists know this. It is called Hammersmith regime. So then, severe disease more in elderly female. This is a kind of a confusion. This is an option where some of us got confused. Elderly people present with isolated renal disease. These are two options where you can get confused. But definitely you know that the first one is wrong. Now, this is again something that we have discussed in class. What have we discussed in class? That 75% of people actually come with lung manifestations first. 25% come with renal manifestations first. The people who come with lung manifestation first are young males. The people who come with renal manifestations first are elderly females. Young males having lung manifestation, elderly female having renal manifestation first. Okay. Young males having lung manifestation first, elderly females having renal manifestations first. Out of which is better? That is where I told you, we may think that, okay, renal is better. No, but it is not. Lung presents early, so lung is better and renal is bad. So isolated RPGN if more than 50 years old, females more than males, and that is very bad. Young male and elderly females are actually prone for anti-GBM disease. More pulmonary involvement, males more than females, that is young males. That is actually better in comparison to elderly female having isolated renal involvement. So elderly female with isolated renal involvement in comparison to young male with isolated lung involvement first has actually got a bad prognosis. That's why this question, severe disease more in elderly female, severe disease more in elderly female is actually correct. That has got a more bad prognosis. Elderly person with isolated renal disease, yes, only place where you get isolated renal disease is mostly elderly. It's more than isolated renal disease presenting with renal first. So now if you read all the 4 options, this is a right statement. It's a tough question. You have to be knowing that there are 2 peaks for good pasture. One is young and second is elderly. Young is male, elderly is female. Male is lung first presentation, 75%. Elderly is female, that is renal first presentation. Lung first presentation has obviously got a better prognosis. Both are bad, but in a way, if you try to compare between the two, lung first presentation is often got a better prognosis than renal first presentation. So that's why you have to think of it like that. So pulmonary hemorrhage more in young females, definitely wrong. Pulmonary hemorrhage more in young males. Hammersmith regime is the name of the regime, that is steroid, cyclophosphamide and plasma exchange, of which the cornerstone is plasma exchange. I've told you that the criteria that have to be satisfied: ongoing pulmonary hemorrhage, actively treat; good output, actively treat; creatinine less than 5.5, actively treat; anti-GBM ANCA double positivity, actively treat; new crescent, cellular crescents, actively treat, otherwise don't treat. Severe disease more in elderly female, we have discussed this. Elderly people, isolated renal involvement or first renal presentation, bad prognosis. Elderly person with isolated renal disease, yes, young, active lung hemorrhage, elderly renal presentation. It's a very indirect kind of a question. Only if you have learned this very specifically and very clearly, then you will be able to answer this. So I put this as a tough question. Although this one option looks very simple. If you have learned the concepts behind good pasture, and if you know this, that it is a young male who presents with lung hemorrhage, and this photo that I have showed you, the X-ray that I have showed you, then you will be able to mark out this. But the other 3 statements are not that very straightforward. So that is question number 2 on glomerulus. We go to question number 3. Young male 20 to 25 years, FSGS, treated with steroid and tacrolimus for 18 months. Proteinuria did not remit. What is the next step? This is very simple. First of all, I don't know who will treat for 18 months, because we say 4 weeks is steroid-assisted nephrotic syndrome in a child, 4 months is steroid-assisted nephrotic syndrome in adult. The moment you are having steroid-assisted nephrotic syndrome in adult, 4 months, okay, you can at the most extend your treatment by 2 more months and go for maximum 6 months. Beyond 6 months, nobody would ever try treating with steroids alone in FSGS. And the moment you are having steroid-resistant FSGS, the first thing that we look for is whether we are having genetic forms of FSGS. Children, we have genetic forms of FSGS. Adults also, we have genetic forms of FSGS. All these autosomal dominant genetic forms of FSGS, including alpha-actinin, TRPC6, and all that will come to our mind. Obviously, we have to check for genetic testing. IV cyclophosphamide has absolutely no role in FSGS. Repeat biopsy, already it is given FSGS. What the hell are you trying to find out by doing biopsy again? Type of FSGS, etc. has no significance here. Rituximab again has got no major role. It's for mentor study in membranous that is actually shown role. It's not in FSGS. So basically, it is your genetic testing for steroid-assisted nephrotic syndrome. That should have been done much earlier, I guess. So that's it. Even in a child, I told you after 4 weeks, we straight away test for. So this is the complete list of genes where I have told you that you have to remember 3 important things. Alpha-actinin 4, that is FSGS type 1. TRPC6, that is FSGS type 2. INF2, that is FSGS type 5. Okay, it is not FSGS type 3, it is FSGS type 5. Okay, so 1, 2 and 5. So if you look at the original Vihali table, you have this alpha-actinin 4 FSGS type 1, TRPC6 FSGS type 2, INF2 FSGS type 5. All the 3 are autosomal dominant. So, and then this important table. This important table again we have discussed in so many ways. Dennis-Drash and Frazier syndrome, which again I have discussed a lot in detail, especially in development. Dennis-Drash, this WT1 gene mutation, the triad of Dennis-Drash syndrome, which is your early onset male pseudohermaphroditism with your renal failure alongside with Wilms tumor and all that thing. So FSGS is what you actually see here. Okay, and I told you about your NPHP1 mutation, which is your congenital nephrotic syndrome, which is autosomal recessive, and there you have mesangial sclerosis, okay, and gonadoblastoma is what you see in Frazier. Comparison between the two you can actually see in a new module that is released alongside with Delta, where I try to compare between a few developmental disorders. Neil-Patella syndrome, autosomal dominant, LMX1B, we know that. Pearson syndrome, autosomal recessive, LAMB2. Okay, repeated question is microchoria. Galloway-Mowat syndrome, autosomal recessive. Important question is abnormal cerebral gyrus patterns and seizures. Okay, all this we have discussed in detail already. So this is a simple question. It's not a extreme higher order concept based question or anything. It's a simple question. So genetic testing. I think most of the people got this right. This is a question which some people got wrong. This is a question also which some people got wrong. This is a question which most people got right. So 10-year-old patient, microhematuria, proteinuria, maternal uncle died at a young age. So Alport, what is false about Alport? True about Alport except. Most common cause is call for A5. You know that 80% are because of call for A5. Then call for A3, A4 according for the remaining. So call for A3, A4 autosomal recessive is 10 to 15%. 5 to 10% is autosomal dominant. This is right statement. Ear complications are more than eye complications. We discussed this so many times. 80% or more you are having this SNHL and 20 to 25 only you are having lenticonus. So that's a right statement. Anti-Gbm disease after transplant, everybody knows because we've discussed the case and a lot of things we've told about that, because you're born without alpha-3 and then suddenly when you get an alpha-3, you are having antibody against alpha-3. That is called anti-Gbm disease. Anti-Gbm disease also everybody knows. Mosaic pattern on skin biopsy stained with anti-call for A5, that is completely wrong. Because call for A5 means when you're having a patient with call for A5 defect, male patient means then you're having no staining whatsoever. Female who is a carrier can have actually a mosaic pattern. And you know that people are born with alpha-1, alpha-1, alpha-2 at birth, which later converts to alpha-3, alpha-4, alpha-5 and alpha-5, alpha-5, alpha-6. Okay, alpha-3, 4, 5 is what you see at the glomerular basal membrane. You see at the level of the eye. You will see at the level of the cochlear basal membrane. 5, 5, 6 pattern is what you see at the level of the skin. Okay, so skin immunofluorescence we look for to find out the mode of inheritance. That means alpha-5, if you see that there is no staining, then you can actually say that this is X-linked. And if alpha-5 staining is actually speaking normal, skin staining is actually becoming normal, that means that alpha-5 is okay, which means that then it is autosomal dominant or autosomal recessive. And here again, we can see this very clearly mentioned that if you are having a staining pattern like this, for example, in a normal male for alpha-5 at the dermoepidermal junction, you can see very good staining. Affected person, you can actually see that there is no stain. And female who is a carrier, you can have mosaic pattern. So female carrier, you can have mosaic pattern. Affected person, you are having no staining. And normal person, you are having normal staining. Again, same thing. Normal alpha-5, X-linked alports male, no staining. Female, this is called mosaic stain. Okay, asymptomatic persistent microhematuria, correct. Gross hematuria following URI, never consider Alport. Most common ENT manifestation is sensory neural hearing loss, 90% males. Dash is the ocular lesion, pathognomonic, that is anterior lenticonus. Why I said like that is because if you ask most common ocular lesion, Doctor plaque retinopathy is the better answer, but there is no significance. And invariably goes to ESRD by 30 years. Eye manifestation has got high correlation with ESRD. So we have discussed everything about this. Remember, call for A5 is the most important thing, of which males are definite to go to ESRD. Females, for your exam, we study they are carriers. So males, when we do biopsy, we get no staining for alpha-5. Females, we get this pattern called mosaic pattern. This is the simple answer. And call for A3 and call for A4, we get autosomal dominant and autosomal recessive disease. Autosomal recessive disease produces severe disease in both sexes. So female getting ESRD is autosomal recessive. Autosomal dominant is mild in both sexes. So that's a very simple question. I don't think there is anything confusing with respect to that. Let us go back to the question. Most common is called for A5, correct. Ear complications more than eye complication, very true. Mosaic pattern when skin biopsy stained with anti called for A5. No, that is not for Alport. That is actually for a female, that is who's actually having a who is a carrier for Alport more than anything else. Anti-Gbm disease after transplant is a right state. Okay, then we had this very simple straightforward question on hypercholesteremia, hypoalbuminemia, image suggestive of MCD. What is the first treatment? So we give steroids. I don't really want to discuss that. So those are the very easy questions that you get in between. So when you look at these 5 questions, 1, 2, 3 are very simple. This is slightly tough question. This is also slightly tough question. But I think if you know the concept behind PAN, there won't be any confusion. And similarly, if you know that male pulmonary hemorrhage, if you think it that way, think about it in that way, you will be able to answer this. Okay, so those are the 5 questions. once again to show you this MPGN pattern. I'm telling you this is very, very, very important. MPGN pattern, see whether it is an immune complex pattern or whether it is a C3 predominant pattern. Once it is a C3 predominant pattern, then we know that it is a C3 glomerulopathy. C3 glomerulopathy is divided into two types. C3 glomerulopathy is divided into DDD and C3GN. When you are having intramembranous deposits, that is called DDD. When you don't have intramembranous deposits, then that is called C3GN. Then this granular staining, you call it as immune complex predominant MPGN. Immune complex predominant MPGN, mostly we think for whether it is polyclonal or monoclonal. Polyclonal means you think mostly about HCV and you think about cryo. Then you see for whether it is monoclonal. When it is monoclonal, then you start exploring. When it is monoclonal, I told you look for congruent positivity. If it is congruent positivity, you start thinking about amyloidosis. If there is congruent negative, then you start thinking mostly about monoclonal immunoglobulin deposition disease. You think about immunotactic glomerulonephritis. Then we start looking into the electron microscopy, organized, non-organized and all that. Yes, secondary causes for membranous, again we have discussed this in great detail. Most important is obviously HBV, but remember that HCV can also be there, and all the other causes we have discussed. The importance of anti-PLA2R, again we have discussed in detail. The importance of thrombospondin 7A, again we have discussed in detail. A lot of new markers that have come up. Importance of drugs like penicillamine and mercury, importance of diseases like rheumatoid arthritis and IgG4, all that we have actually seen. Secondary causes of FSD is also a very important question. Almost everything we have discussed over here. Please go back and see all that in detail. The importance of SUPAR here, the importance of PLAR and membranous, the importance of heroin, the importance of pamidronate, tyrosine kinase inhibitors, obesity, sickle cell anemia, cyanotic congenital heart disease. Then of course when you are having reduced nephron mass, you have adaptive FSCS, which is called the secondary FSCS, perihilar FSCS. The difference between primary FSCS and secondary FSCS, one produces nephrotic syndrome, the other produces only nephrotic range proteinuria without syndrome. All that we have discussed in detail. Okay, so please go back and see all that. These are all extreme high yield areas. And involvement of polyarteritis nodosa, all the involvements in polyarteritis nodosa, but very, very important to keep in mind that it is renal, vascular and not parenchymal, lung also vascular and not parenchymal. Treatment of choice for anti-Gbm, that is steroid, cyclophosphamide and prednisolone. Okay, so thus we come to the end of this unit, which is your glomerulus. So now we have discussed the first three, rare glomerular diseases and original glomerulus, that is total 8 questions. Then we have also seen the hereditary cystic part. We go to nephrorheumatology crosstalk, 4 questions we have over there, all for a very easy, simple, straightforward question. Question number 1 was a patient with hemoptysis, hematuria, proteinuria, lethargy, scleritis, epistaxis, infiltrates full on the X-ray with only mild eosinophilia. They don't remember the options exactly. I think it was GPA, EGPA, MPA and cryo. These were the 4 options. The very simple straightforward question. GPA, upper respiratory tract involvement 95% patients, lower respiratory tract involvement 90% patients, and your renal involvement 60% patients is basically what we call as GPA, the old Vagueness granulomatosis. Upper respiratory tract involvement can be in the form of your serous otitis media, it can be in the form of midline nasal deformities, it can be in the form of your sinusitis, it can be in the form of epistaxis, it can also be in the form of your subglottic stenosis. Okay, all these things are possible. Lower respiratory tract means you can have nodules in the lung, and remember these are thick wall nodules, which are thick wall cavitating nodules. We can also have DH like presentation, and renal involvement is always RPGN type 3. RPGN type 3 presentation, severe forms are seen only in 2 diseases. One is your Vagueness or your GPA, and then microscopic polyangitis. Microscopic polyangitis versus GPA, all the major points of difference, everything we have discussed. It's a very simple question. Scleritis per se is seen only here, because if you look into the ocular manifestations, MPA, EGPA, etc., there are no ocular manifestations. Epistaxis itself means it is very clear. It's a very straightforward question. There is absolutely no. This is thick wall nodule. This is RPGN with your crescent and your DPGN kind of presentation. Recurrent epistaxis, episcleritis, orbital tumors, arthralgia, peripheral neuropathy, all these things should make us actually think of this. Yes. Okay. So how do you differentiate between Vagueness and microscopic polyangitis? Very important. Microscopic polyangitis, upper respiratory tract manifestations are seen only in 30%. Vagueness, it is seen in 95%. Upper respiratory tract manifestation, microscopic polyangitis is only sinusitis. You don't get to see anything else. Whereas in Vagueness, you can get epistaxis, you can get subglottic stenosis, you can get serous otitis media, you can get midline nasal deformities like septal ulcers, crusting, perforation, this and that, everything you can get. Here, all that is not possible. Lower respiratory tract manifestation in microscopic polyangitis is only DH, whereas in Vagueness vagueness, you can get nodules, you can get cavitating nodules, everything. Here all that is not seen. RPGN type 3 is exactly the same for both. RPGN type 3 is exactly the same for both. Remember that is a more predominant C ANCA disease, and MPGN, sorry, microscopic polyangitis is more of a P ANCA predominant disease. Then when you go to the minor manifestations, ocular manifestation, that is scleritis, is seen only with vagueness. It is not seen with microscopic polyangitis. Skin manifestations are actually speaking more prominent in microscopic polyangitis. Peripheral neuropathy is actually more prominent in vaguenous granulomatosis. So peripheral neuropathy is more prominent in vaguenous granulomatosis. Skin manifestations are more prominent in microscopic polyangitis. Okay, so that's it. So if you want to differentiate, when you write the word nodules and cavity, straight away you go and mark it as vagueness. Upper airway disease, vagueness. Skin, microscopic polyangitis. Peripheral neuropathy, more of your vaguenous granulomatosis. Simple question. So second question, C3, C4 low, ANA, ANCA, Anti-Gbm, everything negative. Patient having parotid swelling, patient having mild eosinophilia. All these things related together, IgG4, and I have mentioned IgG4 so many times. Please go back and watch. IgG4 is a sure shot question because it is something new on the blog. They always have this tendency to keep on asking you about IgG4. The moment you think of IgG4, most common things that have to come to mind, of course, type 1 autoimmune pancreatitis is the single most important manifestation. Submandibular disease, orbital, periorbital lesion, lymphadenopathy, retroperitoneal fibrosis. These many things have to come to mind. As far as kidney is concerned, IgG4 related disease presentations are most often tubulointerstitial. So tubulointerstitial kidney disease is what has to come to mind first. Second, there can be retroperitoneal fibrosis and bilateral HUN presentation. Retroperitoneal fibrosis, bilateral HUN presentation. Rarely there can be membranous nephropathy with low C3, low C4. So membranous nephropathy with low C3, low C4, that can also be there. So tubulointerstitial, bilateral HUN, membranous nephropathy, all this. Okay, so tubulointerstitium, kidney diseases which involve, so retroperitoneal fibrosis, tubulointerstitial nephritis is more common than membranous. Thickening of the bronchovascular bundle, NSIP, paravertebral mass. All these are very important because thickening of the bronchovascular bundle is one reason why it is always compared to sarcoidosis, because sarcoidosis also has thickening of the bronchovascular bundle. NSIP is the most common manifestation with respect to almost all the connective tissue diseases. Paravertebral mass as well as aortic involvement, aortitis, are again things which can differentiate it from the others. You can have a detailed look at it in the rheumatology part of it, where we have done a detailed discussion on IgG4. As far as kidney is concerned, this is more than enough. And of course, this storiform fibrosis and your bird eye appearance and so many other terms that we have, cartwheel appearance and things which we actually use over here, so that you can actually go back and see. But it's very important to understand the ways it can come to you. So when it actually comes to you as a question for the exam, either it can come as a tubulointerstitial disease. When you have a tubulointerstitial disease, what comes to your mind? Rheumatological conditions which have a predominant tubulointerstitial component are sarcoid, Sjogren, IgG4, 3 diseases. Sarcoid also has a tubulointerstitial component, Sjogren also has a tubulointerstitial component, IgG4 also has a tubulointerstitial component. What differentiates IgG4 from the others are obviously going to be, one, the importance of type 1 autoimmune pancreatitis, which is obviously going to be there. Then swelling. Salivary swelling per se is not classical in Sjogren. Sjogren does not have so much of salivary swelling. Sjogren has more of Zika symptoms, whereas here you are having more of salivary swelling, less of Zika symptoms. And Zika symptoms in Sjogren don't respond to steroid. Okay, Sjogren as a disease is steroid responsive, but Zika symptoms don't respond to steroid. Whereas in IgG4, Zika symptoms, though minimal, got extremely good response to steroid. Okay, so that's about it. So you have IgG4 containing lymphocytes and plasma cells. You are having IgG4 containing lymphocytes and plasma cells. You are having something like mild eosinophilia there. So that's also right. Mild eosinophilia is part and parcel. Okay, plus phlebitis, plus lymphoplasmacytic cells. So very important topic, just to once again make you understand that RPGN and the connection with type 3 RPGN is very important with respect to nephrology. And the causes are all rheumatology causes, the ANCA positive causes. Then IgG4 is a very important exam zone. We go to question number 3. Question number 3 is a 26-year-old female who is a known case of lupus nephritis on steroid TAC MMF regime. She defaulted drugs and after 6 months, she had 12 weeks amenorrhea and UPT came positive. Creatinine is 1.6, PCR is 1.8 and she has proteinuria with RBCs in urine. So she has activity and she has become pregnant. Okay, while having active disease, she has become pregnant. She was taking all these drugs. What do you do next? Okay, we have a separate subtopic under pregnancy, what we have discussed, called lupus and pregnancy. And it's very clear that remission for at least 6 months before conception. Okay, and active disease increases fetal risk manifold, and hence proteinuria less than 1 gram per day is mandatory. Aspirin plus HCQ in all patients, continue maintenance steroid. And that makes it very simple and very clear that you have to discontinue pregnancy. MTP is the answer. So not because MMF is teratogenic or anything. Lupus, it's mandatory that remission is required for 6 months. This patient is not in remission. So there again, too much of the complicated thought process is not required. If you think simple and straight, you can come to the answer. So this is the next question on rheumatological diseases. This is again something that we have discussed alongside with pregnancy. This is my own slide. So lupus and pregnancy, 30% in third trimester, 15% postpartum. Okay, step up steroid and azathioprine, reserve biopsy. Fetal outcomes are in much affected, but still there is definitely chance. Prior nephritis is always a risk. Okay, anti-Ro antibodies and the risk for congenital heart block. Yes, we've discussed this in big detail. Next is on type 2 cryo. What is type 2 cryo? Simple question. Type 1 cryo is just monoclonal IgG or IgM. Type 2 is actually monoclonal plus polyclonal. Monoclonal IgM and polyclonal IgG. And type 3 is pure polyclonal IgG IgM. Type 1 is a hematologist cup of coffee. Type 2 and 3 are rheumatologist cup of coffee. Type 2 and 3 you actually associate with your Sjogren as well as with HCV. So it's a very important association. And then of course sometimes SLE. But type 2 and 3 we always think about Sjogren, HCV, and rheumatoid factors positive in type 2 and 3. Type 1 is about Waldenstrom's macroglobulinemia because it is mostly monoclonal IgM. So it's a very simple question. Anyone and everyone who have seen about cryo will be able to answer this. But it should have been actually a rheumatology question, but it came under nephrology. So that's it. So we have 4 questions this time around on rheumatology and nephrology overlap. Rheumatology and nephrology are 2 subjects which have got lots common with each other. All these 4 questions are simple, straightforward questions. I don't think there is any confusion with respect to answering any of these questions. I think all of you should have got these questions right. So nephro rheumatology crosstalk questions are easy this time. So from the 4 units that we have discussed so far, apart from those 1 or 2 questions in glomerulus and that one prop KD question, I think the rest of the questions are pretty much okay. And nephrology is one subject where the cutoff scores are not going to be very high, unlike in neuro, rheumatology, etc., where most people answer all the questions. Here, even if you score about 60-70%, you are in with a very, very decent chance, extremely decent chance. Okay, that is how the pattern of the subject is. The pattern of the subject is one where it's not easy to score so much marks. Okay, not at all easy to score so much marks. I remember the Kerala entrance where I actually topped the list was one exam where out of 720, my score was only around 500, 520 or 525, which means that it's not a big thing. It's not like you have to score full marks to get a top rank. It's not important. So that's about that. We go to vascular disorders. 3 questions on vascular disorders. 3 tough questions, I guess. Solid phase component factor in atypical HUS. Solid phase component factor in atypical HUS is a question if I had got for the exam, I would have thought that this is complement factor H, this is complement factor I, this is complement factor B. They are soluble factors. Membrane cofactor P is a membrane bound factor. Because it is a membrane bound factor, this is a soluble phase factor, solid phase factor. Membrane cofactor P is the correct question, but correct answer. But it's very difficult to make out. If you really don't know, it's hard to actually guess. Only way to think is this. That means if you look through all the things, we've got this big list of factors which are activated in your atypical HUS, which is a disease that is associated with activation of your alternate complement pathway. All of us know that it is associated with activation of alternate complement pathway. We know that complement factor H is the single most important cause. Complement factor B has got the worst prognosis. Membrane cofactor P has got the best prognosis. This I think I have taught you and I think everybody knows this. But if you see this complement factor H, you can see it is a circulating protein. Complement factor B, circulating zymogen. Then you look at your complement factor I, that is again a circulating protein. So all these are basically circulating things. And when you look at membrane cofactor P, it is a membrane bound complement inhibitor. It is a membrane bound complement inhibitor. So that's it. This complement factor H is also an inhibitor of the alternate complement pathway. Okay, this complement factor B, so see complement factor H you can see over here, suppresses the alternate complement pathway. Complement factor I suppresses the alternate complement pathway. Membrane cofactor P suppresses the alternate complement pathway. Whereas complement factor B alone promotes the alternate complement pathway. So when you're having a loss of function mutation of complement factor H or I or MCP, we get atypical HUS. But when you're having a gain of function mutation of complement factor B, we actually get this atypical HUS. So complement factor B is a gain of function mutation that has got the worst prognosis. All the others are loss of function mutation, of which MCP has got a better prognosis. This question is a tough question. The only way to answer this is knowing that this is membrane bound and the others are circulating. Tough question. Okay, but some people use this logic and they were able to come to the answer, but that has to click when you're sitting in the exam hall, and that's not an easy thing. And I think that is what requires blessings from above. Second, class 1 indication for plasmapheresis is which drug induced TMA? This again is a question where I feel very bad. Because if you look at what I have taught in class, let us come to that. TTP, I told you we can have genetic, which is due to mutation in gene for Adams 13. Acquired is because of antibody. That is 95% is acquired. And then I have told you post-HSCT, malignancy, HIV, ticlopidin, clopidogrel. These are the 5 most important causes where class 1 is plex and then rituximab. Which means everybody knew that so many drugs can cause HUS, but only 2 drugs can cause TTP. Ticlopidin and clopidogrel are those 2 drugs where we have to actually go for a plex. Which meant that the moment students saw these questions, they knew that these were wrong. It is either ticlopidin or clopidogrel, but how to differentiate between the two? Seriously speaking, I also don't know. This is one question for which I don't know the answer. I knew that ticlopidin and clopidogrel are 2 drugs for which plex is class 1 indication, and that you have to be using it for drug-induced TMA, which is a TTP-like kind of a situation. Now, again, what to choose among this? Now again, I had to read and I understood that. So I had to dig deep and find out. So what I have understood is response to plex is 90% in ticlopidin-induced DTP, and response to plex is only 50% in clopidogrel-induced DTP. So because response to plex is 90% in ticlopidin and only 50% in clopidogrel, the answer to this question is ticlopidin. Okay, that's a tough question. But again, if you're eliminating 2 options, you have 50% chance. I never knew that ticlopidin has 90%. We're not using ticlopidin now, first of all. Clopidogrel-induced DMA, I have not seen, to be frank with you. So ticlopidin-induced DMA, clopidogrel-induced DMA, both I have not seen. Plex being done for TMA itself is a very rare thing. So, I mean, plex being done for, I'm saying TTP itself is a very rare thing. Plex being done for HUS is pretty common. So this is a TTP kind of a question where plex we are doing as a class 1 indication for which drug induced TMA or TTP. This was the question. Answer is ticlopidin. So that's a tough question. Then we have this third question on vascular. Patient with homocystinuria presents with DVT, what food will you recommend to prevent thrombosis? It's a very simple question because homocystinuria, again, you know, cystathione beta synthesis, the enzyme, cofactor for cystathione beta synthesis, pyridoxine. So naturally, that's an MBBS level question, MBBS biochemistry level question. Pyridoxine is what you actually supplement. There's nothing to teach you there. So many reactions for pyridoxine are cofactor, including transamination, decarboxylation, and the cystathione beta synthesis and all that. So that's a simple question. The tough questions here are the first 2. So vascular, this time around you have 2 tough questions, not pretty easy to handle. We go to pregnancy. Not true about renal physiological changes in pregnancy. Not true about renal physiological changes in pregnancy is a very, very easy pick. We'll come to that. Second question was, which of the following is not true about gestational hypertension? So we'll just try to see these 2 questions in pregnancy. Not true about renal physiological changes in pregnancy. Increase RPF, increase size and volume of the kidney, fall in PCO2, increased RAS sensitivity. Okay, let us try to see through the options. Progressive dilatation of the pelvic calcium system, ureter more on the right side. Plasma volume increases, RBC increases, cardiac output increases, GFR increases, and you can actually see that GFR increases due to enhanced perfusion, increased compliance. Then you can see that normal creatinine pregnancy is 0.3 to 0.6. Renal plasma flow increases by 80%, but still the capillary pressure does not increase so much. We've discussed that. Filtration fraction is GFR by RPF, and I told you that RPF increases more than GFR, so filtration fraction actually speaking false. So GFR increases, RPF increases, cardiac output increases. The only thing that decreases is actually your BP, because you are having a fall in resistance, vascular resistance mediated by prostacyclin, nitric oxide, progesterone, etc. So all these things are actually speaking right. So let us go back to this question. Increase in RPF, right statement. Increase in size and volume of the kidney, perfectly right statement. Fall in PCO2, obviously there is some hyperventilation. Hyperventilation will drive out carbon dioxide, there will be fall in PCO2. This is also right. So these 3 statements are pretty clear. Even if you don't know this, you can actually mark it by elimination. But again, we have discussed the same statement. You can see RAS activation is there due to vasodilatation, but BP is normal due to the effects of relaxin and downregulation of AT1 receptors. This is exactly what I told you. There is downregulation of AT1 receptors. There is reduced sensitivity that is mediated by relaxin. And osmolality is reset to 270, that is due to ABP. And despite of aldosterone, potassium is kept normal due to anti-mineralocorticoid activity of progesterone. Calcium, magnesium citrate excretion in urine is increased. All these are the points. So we have actually seen this in a lot detail. What happens to your hematocrit? There is slight fall. What happens to serum protein? It's almost normal. Osmolality comes down due to ABP. Sodium, because there is sodium and water intake, naturally you will be having slightly low sodium. Creatinine actually is 0.3 to 0.6. Bun is slightly on the lower side. pH, there is alkalosis, respiratory alkalosis. PCO2 is falling down. Bicarbonate also is like 20 because there is some alkalosis. Uric acid falls during pregnancy. BP is not by 60, slight fall. So we have discussed this in big detail. Okay, every single point with respect to physiological change in pregnancy is important. All the questions have come for the exam. So progressive dilatation of your pelvic calcium system, urinary stasis, that's why when asymptomatic bacteria you have to treat. Plasma volume increases, RBC volume increases, but plasma volume increases more. Cardiac output increases by 40 to 50%. BP falls due to the effect of fall in systemic vascular resistance. GFR increases, RPF increases, but the increase in RPF is more than that of GFR. Normal creatinine in pregnancy is 0.3 to 0.6. There is no value for MDRD, CKD, any of those equations. Glomerular capillary pressure is not high because of equal dilatation of the pre and post glomerular vessels. Filtration fraction falls because it is GFR by RPF, and RPF increases more than GFR. CKD, EPI and MDRD have no value. RAS activation is there, but still there is down regulation. ABP is there, so 270 milliosmoles per kilogram is the new serum osmolality. So despite aldosterone, potassium is normal due to anti-mineralocorticoid effect of progesterone. Calcium, magnesium citrate excretion in urine is increased. Uric acid falls. Mild respiratory alkalosis. Physiological glycosuria. Okay, please mug it up. Every single point is important. So that is the first question. So it's, I think, not a very tough question. Let's go to the second question. Which of the following is not true about gestational hypertension? So this is a question which I think requires you to know things properly. What did I teach you? When you look at hypertension in pregnancy, okay, when you look at hypertension in pregnancy, there are three components, okay. One, we have gestational hypertension. Second, we have preeclampsia. Third, we have chronic hypertension. And what did I tell you? A hypertension that is diagnosed before 20 weeks, okay, a hypertension that is diagnosed before 20 weeks is actually called as chronic hypertension. 140/90, 2 times 4 hours apart. It's actually chronic hypertension. 20% of the people are having chronic hypertension. This I told you. Then what did I tell you? Remaining almost 80% are actually having gestational hypertension. What is the meaning of the term called gestational hypertension? Gestational hypertension means same, but it is after 20 weeks that you have the diagnosis. So after 20 weeks you have a diagnosis, that is called gestational hypertension. Inside this gestational hypertension, if you are having any one out of 1, 2 or 3, then that is equal to preeclampsia. Previously this was not the way. You need to have mandatorily, you need to have proteinuria, mandatorily you need to have this, that, nothing like that. Now any one out of the 3 you can actually call it preeclampsia, out of which one is proteinuria. Second is you are having markers of end organ damage. End organ damage like a liver enzyme high, or upper abdominal pain, or a neurological involvement, seizure, hyperreflexia, anything like that. Okay, so with gestational hypertension, if you have any one out of these 3, then we call it as preeclampsia. First is proteinuria, second is end organ damage. End organ damage can be upper GI pain, can be a rise in liver enzymes, can be a thrombocytopenia, can be a neurological involvement with seizures, anything. And the third one is actually speaking IUGR. So third one is IUGR. So proteinuria or end organ damage or IUGR is basically what we call preeclampsia with what? Gestational hypertension. What is the eventual outcome? This is the eventual outcome. 12 weeks of postpartum, 85% will have resolution. Okay, so what is that called? That is called transient hypertension. And 15% will have persistence, that is called as chronic hypertension. So you take this big group of people who are having gestational hypertension, see for whether it is a simple gestational hypertension or a preeclampsia. Preeclampsia, you say if there is IUGR or end organ damage, or if there is proteinuria. Suppose that is not there, then you call it gestational hypertension. 85% of the population at 12 weeks postpartum will have resolution, that is called transient hypertension. 15% will have persistence, that is called chronic hypertension. Okay, this I have made very clear. This we have discussed in detail. Let's now see what the original question was for the exam. The question for the exam is, which of the following is not true about gestational hypertension? There is no risk for preeclampsia in the postpartum period. There is no risk for preeclampsia in the postpartum period. Gestational hypertension and risk for preeclampsia, etc. has not been studied. We'll just come back to this option. Aspirin decreases the risk for preeclampsia. You know that now. Now, previously the concept was The girl had increased resistivity index on the uterine artery Doppler, which was done between 18 to 20 weeks. Then they used to start her on aspirin because it was found to have a definite role in preventing preeclampsia. But now if you are having a girl who is supposedly in this risk category, that means family history of preeclampsia, or she herself is more than 30 years old, etc., straight away these obstetricians start her on aspirin because it has a definite role in preventing. It's a gynecological thing which most people know. That's it. Now, resolves completely postpartum. Which of the following is not true about gestational hypertension? Gestational hypertension resolves completely. I don't know how much it is true because 85% it resolves postpartum. So just keep this in reserve. There is risk for fetal growth retardation in gestational hypertension. That is definitely wrong because there is no risk for fetal growth retardation. If you have fetal growth retardation or IUGR, then you call it as what? Then you call it as preeclampsia. It is not gestational hypertension. So when you say gestational hypertension, then it is definitely not equal to any growth retardation. There is no risk for preeclampsia in the postpartum period. Again, I don't know how to take that option. There is no risk for preeclampsia in the postpartum period. What preeclampsia out of gestational hypertension? I think there is no risk. There is no risk for preeclampsia in the postpartum period. And gestational hypertension is not a risk factor for preeclampsia. Gestational hypertension, under which few patients have 1 out of the 3, that is called preeclampsia. So these are the statements that we got. Out of this, I feel this is the answer because the basic definition of gestational hypertension in itself is not without these 3. If anyone, that is end organ damage, or you are having something like a growth retardation, or you are having proteinuria, then that is not gestational hypertension, that is called preeclampsia. Did you understand my point? Which means when you're trying to classify itself, we are having 3 categories, right? Hypertension in pregnancy is gestational hypertension. Without these 3 things, 1 out of these 3 things, it becomes preeclampsia. When detected before 20 weeks, it is called chronic hypertension. Now, at the end of 12 weeks postpartum, 85% resolve, that is called transient hypertension. 15% persists, that is called chronic. So with that in mind, if you try to look into the question, then you understand that the basic point in this question is about risk of fetal growth retardation, which is not there. Resolves completely postpartum. See, the textbook definition is actually like that. That's why probably they have put an option. See, they have written like returning to normal within 3 months. But actually speaking, it's not that way. 85% only return to normal. So because Vihali says so, we'll also stick with Vihali and we think that's right. This first statement really don't understand. There is no risk factor per se like that. So there is no risk for fetal growth retardation. So that's the statement. They've given it as risk, so that's wrong. That is the next question. So these were the 2 questions on pregnancy. One more question was there, which was the lupus question that we discussed. Okay, we go to AKI. AKI, first question is very, very simple. Gym, AKI, CPK very high, dipstick was positive. What is there? This is a very simple question. You are having myoglobinuria. Okay. Now, this question is essentially trying to check out for whether you know what are the causes for exogenous AKI, endogenous AKI, under endogenous AKI, what's the type of injury, etc. This we have discussed in great detail. Intrinsic AKI can be a tubular injury or a tubulo-interstitial injury. Tubulo-interstitial injury is what we call acute interstitial nephritis, which is mostly due to drugs. Tubular injury can be ischemic AT and it can be endogenous toxins, exogenous toxins. Endogenous toxin is mostly your myoglobin. And I have told you that anybody with any form of exercise having any kind of a collapse or having anything to do with your muscle pain, high colored urine, everything, it's equal to rhabdomyolysis. Approach to high colored urine, we have done a separate module on that. Approach to high colored urine is use dipstick positive, dipstick negative. Dipstick negative is porphyria. Dipstick positive can be due to blood. RBCs can be due to hemoglobin, myoglobin. They do centrifugation. The end of centrifugation, the supernatant becomes clear. Then it is RBC. Otherwise, it is hemoglobin, myoglobin, everything we have discussed. So nothing more to discuss on that. And it is characterized by everything coming out. So uric acid will come out, potassium will come out, phosphorus will come out, phosphorus will trap calcium, so we get hypocalcemia, hyperphosphatemia, hyperkalemia, and all those things. Okay, that's it. And you can see non-protein heme pigment released from myoglobin, which is tubular toxic. PCT injury with vasoconstriction is the mechanism. Lot of third space loss. So because of that, you can see that in rhabdomyolysis, just like with contrast and NSAID, sphena is less than 1. Muscle pain and dark urine with muscle swelling, please jump and mark the answer. Pigmented granular cast in urine, mark the answer. Oliguria, no, it is a non-oliguric renal failure that you're having here. Because of non-oliguric renal failure, you need to hydrate the patient properly. CPK definitely above 1500 units, starts to rise after 2 to 12 hours and peaks in 1 to 3 days. It decreases over 3 to 5 days. Myoglobin has a half-life of only 3 hours and serum level normalizes in 6 to 8 hours. So basically looking at myoglobin alone, you cannot make a diagnosis. CPK will help you. Anybody having muscle pain, muscle swelling, high colored urine, high CPK, rhabdomyolysis, hydrate, patient will come out. Generally does not require dialysis, generally has a good prognosis. Simple question, and we've discussed everything about this. Question number 2, NSAID intake causes all the following except. NSAID intake, can it produce nephrotic syndrome? Of course, when we looked at membranous nephropathy, when we looked at MCD, we looked at drug-induced MCD, one cause was NSAID. We looked at drug-induced membranous, one cause was NSAID. Drug-induced MCD, I told you about NSAIDs and interferon alpha. So naturally, that's the right answer. Okay. Can it produce hypertension? NSAIDs per se producing hypertension as a part of glomerular involvement is very, very well known. So there is nothing that is wrong over there. Drug-induced papillary necrosis, we've discussed so many times drug-induced papillary necrosis. NSAID is one of the causes for papillary necrosis. Can it produce metabolic alkalosis? Now, the second context where we have actually studied NSAID, and what is so unique about NSAID is this tendency of NSAIDs to produce hyperkalemia. And hyperkalemia is often associated with acidosis, and where we have studied something called RTA type 4. Okay, I hope you remember this. That means whenever a patient has hyperkalemia, it goes without saying that it is because of renal failure. Hyperkalemia is due to renal failure unless proven otherwise. Whenever somebody has a hyperkalemia, that is disproportionate, okay, that is disproportionate to the degree and duration of renal failure. So somebody has a hyperkalemia that is disproportionate to the degree and duration of renal failure. This hyperkalemia that is disproportionate to the degree and duration of renal failure is what we actually call as RTA type 4. Okay, this RTA type 4 is because of something that is, it's got something to do with aldosterone, or it has got something to do with hypoaldosteronism or low aldosterone. This low aldosterone can be a true hypoaldosteronism, or it can be a pseudo hypoaldosteronism where aldosterone is not able to bind to the receptor. True hypoaldosteronism can be divided into hyporeninemic hypoaldosteronism, which is got to do with low renin, or it can be due to hyperreninemic hypoaldosteronism. Correct, hyperreninemic hypoaldosteronism. That means aldosterone is low but renin is high. When aldosterone is low and renin is high, obviously you think of what cause? You think of Addison, because it has got something to do with the adrenal. Okay, or you can also think of ACE inhibitors, you can think of ARBs, you can think of warfarin, all these things. Sorry, not. You can think of ACE inhibitors, you can think of ARBs, you can think of heparin because it inhibits the enzyme called aldosynthase, all those things you can think. But when you think of hyporeninemic hypoaldosteronism, that means no renin, no aldosterone. First thing that comes to mind is things which block renin. Okay, what are the things that can block renin? Naturally, NSAIDs and beta blockers, because beta 1 is required for synthesis of renin. NSAIDs block prostaglandin. Prostaglandin is again required for synthesis of renin. And diabetic nephropathy is one condition where prorenin to renin conversion is impaired. It is also a condition where beta 1 impairment due to autonomic things. So because of that, NSAIDs, beta blockers, diabetes, all these things produce hyporeninemic hypoaldosteronism. So when you are having hyporeninemic hypoaldosteronism, what do you get? We get RTA type 4. What is RTA type 4? Characterized by hyperkalemia with normal anion gap, metabolic acidosis. So you cannot get metabolic alkalosis in NSAID by any means. Okay, it's very simple. Even if you don't know anything, even if you don't know this much, if you have a simple understanding that prostaglandins stimulate renin. Okay, renin produces aldosterone. So prostaglandins lead to potassium wasting. No prostaglandin, hyperkalemia. Hyperkalemia, acidosis. NSAID, acidosis. That way also you can answer this. If you know this properly, that way also you can answer this. Whichever way, if your concepts are strong, you can answer these questions. Okay, PGI2 is the most important one in cortex. PGE2 is the most important one in tubule. COX1 and COX2. COX2 is predominantly in the macula densa. So these are the 5 components of NSAID-induced kidney injury. Oliguric renal failure because afferent arteriole is constricted. FENA less than 1 because it is pre-renal. Within a few days, reversible AKI, hyperkalemia out of proportion. And I mentioned that very clearly it's hyperkalemia out of proportion, because of which it has to be hyperkalemia with acidosis. It has to be a RTA type 4 kind of picture. Yes. AKI markers is a very, very common question, and you know Kim and Galcistatin are correct. Osteopontin has nothing to do here. We have seen all the markers and we discussed a lot about this. We've talked about KIM1, we've talked about TIMP2, we've talked about IGF-B7, we've talked about interleukin 6, interleukin 18, interleukin 10, this furosemide stress test, cystatin C, creatinine, and everything. That's a big discussion, and please keep in mind, at least for your exam, KIM1, NGAL, liver fatty acid binding protein, in TIMP2, tissue inhibitor metalloprotein is 2, insulin-like growth factor binding protein 7, interleukin 18, interleukin 10, interleukin 6, at least this much. Okay, you'll be safe because it's a very common question, very, very common question. Okay, that's about it. It's a very easy part this time around in AK. We didn't have any confusing questions. AK is one topic which is very, very favorite, or which is something which the nephrologists consider as very close to heart. But unfortunately, the entrance examiners don't consider close to heart. AK is one topic, even if you don't know in detail for the entrance exam, you are likely to get away with, because it is one topic where you don't get a lot of questions left and right. General anatomy, physiology, we do get questions many times, but this time around we had only 1 or 2 questions. One question was on cystatin C, which is a routine question. Cystatin C is produced by all cells. I've told this so many times. Cystatin C is produced by all the nucleated cells. Okay, all the nucleated cells. Best for GFR? No. I told you it's always creatine all the time. No studies have shown at any point in time that this is better than creatine. Decreases in steroid intake. What is the problem with cystatin? The main problem with cystatin is that cystatin is non-specifically elevated in people who are on steroid. Cystatin is non-specifically elevated in thyroid patients. Cystatin is non-specifically elevated in inflammation. That is the problem with cystatin. Otherwise, cystatin is a great thing, but these are the issues. It is filtered, reabsorbed and catabolized completely by the PCT. We have discussed this so many times. That's the right answer. Okay, this table is very important. How you compare between cystatin and you compare with creatinine. Cystatin is a non-glycosylated basic protein. It produced by all the nucleated cells. Increases with steroid use, increases in hyperthyroid and increases with inflammation. That's a problem with that. Filtered, reabsorbed and catabolized. And that's it. And this is something which you have to know. Diet, no effect on cystatin. Larger mass, muscle mass, no effect on cystatin. Obesity tends to increase cystatin. So, obesity has no effect on creatinine. It's muscle mass that has effect on creatinine. Obesity has an increasing effect on cystatin. Malnutrition also tends to increase cystatin. But generally, muscle mass effect is much less. Diet effect is much less. Race effect is much less. That is the advantage. But still, for all practical purposes, it is creatinine. And this is exactly the statement. Full implementation will require standardization, greater variability, cost reduction, as well as a better understanding. Yes, bleeding after biopsy, which is not a risk factor. Again, this is a very practical question. We do biopsy for transplant kidney left and right. There you are having only a single kidney. So if it's not a risk factor, means you will not be able to do. Solitary kidney is never a risk factor. Solitary kidney is a contraindication. If you're having only a single kidney, you should not do biopsy. But that's not a risk factor for bleeding. Small kidneys obviously will bleed. There's nothing that you're going to get out of doing biopsy in a small kidney. Low platelet and a high BP, of course. So if you see through high risk factors for biopsy, anemia, PT high, APTT high, creatinine high, BP more than 160, antiplatelets, AKI, small kidney, scarred kidney, needle size less than 16. Most importantly, operator skill. I feel that is the most important thing. These are all risk factors given again in Shire, but I feel this is a simple question. Just trying to test out whether you know a basic fact. Solitary kidney definitely is a contraindication. You shouldn't try with a solitary kidney, but transplant is an exception to that, where there's no risk of bleeding per se. All the others have increases for bleeding. So, contraindication to biopsy, multiple cyst, solitary kidney, pyelonephritis, perinephric abscess, renal malignancy. These are the things. Okay. Then comes unit on metabolism. Now, this is basically, I think, more to do with endocrinology rather than, I think, nephrology. Some of the questions are core endocrine questions. I don't know how many of you were able to tackle this. Licorice ingestion produces what? It is actually used by singers to soothe their throat and for them to get a better performance. Licorice ingestion, we have discussed so many times, is very similar to this condition called apparent mineralocorticoid excess, or what we call AME, which is due to the deficiency of this enzyme called 11 beta hydroxysteroid dehydrogenase. So it is due to a defect in this enzyme called 11 beta hydroxysteroid dehydrogenase, and because of which cortisol cannot be converted into cortisone. Cortisol cannot be converted into cortisone. Because cortisol cannot be converted into cortisone, cortisol increases. Cortisol has glucocorticoid and mineralocorticoid action, whereas cortisone has only glucocorticoid action. So when cortisol has both gluco and mineralocorticoid action, we will have this mineralocorticoid effect predominating. That is why it is called apparent mineralocorticoid excess. Okay, and this we have discussed in great detail once again. Just like approach to hyperkalemia, approach to hypokalemia. Hyperkalemia is due to renal failure unless proven otherwise. Hypokalemia is due to renal loss unless proven otherwise. Renal loss can be associated with acidosis, which is generally a normal anion gap metabolic acidosis with a positive urine anion gap. This is what we actually call as RTA, which can be RTA type 1 or 2. This is on one side. Hypokalemia can be associated with alkalosis. This alkalosis can have a normal to low BP. When it has a normal to low BP, you have two conditions to keep in mind. One is called Gitelman and the second one is called Barter. In Gitelman, you have low magnesium in blood and you have hypocalciuria. So that will help you identify whether it is gentleman. Hypokalemia alkalosis with a high BP. Hypokalemia alkalosis with a high BP. You have Conn syndrome, you have Cushing syndrome, which are the two acquired conditions. Then you have three inherited conditions called Liddle syndrome, apparent mineralocorticoid excess, and your glucocorticoid remediable aldosteronism. So there you have hypokalemia, alkalosis, hypertension. There you are in Bartter and gentleman, you are having hypokalemia, alkalosis, normal to low BP. RT, you are having hypokalemia, acidosis, normal anion gap, metabolic acidosis with positive urine anion gap. Okay, this we have discussed 10,000 times. I don't know how many times I myself have discussed this. Hypokalemia with metabolic alkalosis is the correct answer. Hypokalemia, metabolic alkalosis, hypertension is the complete answer. Okay, it's a very simple question. Second is 60-year-old male presenting with nausea, vomiting, abdominal pain was on metformin and empagliflozin. This question we have discussed 10,000 times. The moment you have empagliflozin, the moment you have SGLT2 inhibitors, you think about euglycemic ketoacidosis, and the same question I have discussed. See, solve the scenario. 57-year-old male, 10 years history of diabetes, lightheadedness, metformin, empagliflozin, HbA1c 5.7, currently on a low carbohydrate diet, again lightheadedness, nausea, tachypnea, and you have this ketonemia. This is again euglycemic ketoacidosis. SGLT2 inhibitors are now the superstars. Now they're part of everything now. And now we find that they've got multiple uses. Now first line drug for heart failure with preserved ejection fraction, SGLT2 inhibitors are there. First line drugs for diabetes, first line drugs for preventing decrease in GFR, everything. The manifold advantages have done an update on SGLT2 inhibitors per se on what has happened with respect to these drugs. You can actually watch that update. So there are so many advantages. Decreased oxygen consumption, decreased cardiovascular mortality, weight loss, reduced epicardial fat, decreased leptin, direct inhibition of sodium hydrogen exchange, decreasing systolic BP, natriuresis, diuresis, but no tachycardia, reduce hyperfiltration. Big time, great. Then ketone body is used as a fuel. That is one issue that you have. Then making cells believe that they are fasting as well as hypoxic, so increasing EPO production, so just to minimize anemia. Reduction in LV mass, that's why very useful in heart failure. Inhibiting inflasomal pathway and thus even inhibiting atherosclerosis. Manifold benefits. Okay, so it's more of a medicine question than a nephrology question, but I think everybody would have answered this. Depressed woman, hypokalemia, hypomagnesemia. Hypokalemia when you are having magnesium loss, along with that simple answer I told you. Hypomagnesemia, hypocalciuria, answer is always gentleman. And we've discussed how to compare between Bartter and gentleman so many times. Bartter, gentleman, RT and all are standard questions. You expect that every time. This is a tough question. Not true about ammonia metabolism. Hypokalemia stimulates ammonia production. Everybody knows. Hyperkalemia depresses ammonia production. Hypokalemia stimulates ammonia production. That's why even in a patient who is in your gastroenterology ward, in a patient with cirrhosis, portal hypertension, what you don't want is hypokalemia. You don't want vomiting. You don't want hypokalemia because that can precipitate ammonia synthesis and that can actually lead on to hepatic encephalopathy. So this is definitely correct. Most metabolism is dependent on distal tubular function. Yes, ammonia synthesis, NH3 excretion combining with H plus NH4 plus production is on distal tubule function. Distal tubule function is mostly your collecting duct. Okay, collecting duct. So if you look at this, you can see that this is your cortical collecting duct. On this cortical collecting duct, this is the luminal membrane. This is the basolateral membrane. On this luminal membrane, we are having this H plus ATPase, H plus K plus ATPase. H plus will actually combine with ammonia and this will actually form NH4 plus. So this NH4 plus is what is excreted in urine and this is what is lost in RTA type 1. We know that in detail. And bicarbonate chloride anion exchanger is on the basolateral membrane. We know that very clearly. This is the collecting duct that we are actually talking about. Okay, so if you look at it that way, most metabolism is dependent on distal tubule function. I don't know how to take it. Distal part of the tubule is okay, but it's actually speaking collecting duct. Still we find fine. RCG helps in shifting urea to collecting duct. Okay, I'm not really sure as to what is this RCG. There is a channel actually here referred to as RHCG. This RHCG and urea, there is basically no relation found out. So this is again an option which I'm not sure and I've not been able to find out. If you find out something with respect to this, please let me know. How does it help you shifting urea to the collecting duct? Because if you look into the urea metabolism over here, there are UTA1, UTA3, UTA2 and all of this we have discussed in detail. Urea transporter A2, which is actually responsible for urea circulating inside here, UTA1 and A3 through which it is actually metabolized and so through which it is actually reabsorbed in the intermediary collecting duct. So I have no idea. But this option is something which is very clear. Pendrin on the basolateral membrane secretes bicarbonate. No. If you look into the collecting duct, another type of cell, you see this is the luminal membrane. We have a bicarbonate chloride exchanger on the luminal membrane. This impairment can also produce RT. This bicarbonate chloride exchanger is based on pendrin. This is the pendrin one. And pendrin bicarbonate chloride exchanger is not on the basolateral membrane. It is on the luminal membrane. So this question, pendrin on the basolateral membrane secretes bicarbonate. No, pendrin on the luminal membrane secretes bicarbonate. This is definitely sure, and I have discussed this along with our ABJ discussion. This is very clear. So this is the answer. This statement, I'm not sure what it means. This statement also I'm not sure, because most metabolism is dependent on distal tubule function is not clear. Distal RT is a term that we use, but does it mean that the problem is in the distal tubule? It actually means that it's in the distal part of the nephron. So whether they meant distal part of the tubule or distal tubule per se, I don't know. Or whether they meant true about ammonia metabolism means this will be the right answer. But that will be so easy a question. So again, question not clear. It's a tough question anyway. Okay, so that's it. If you get more clarity, do let me know. Urine pH more than 6.5, hypokalemia, metabolic acidosis, urine iron gap positive, RTA1, no doubt. Simple question. Not going into the depths of discussion. We have discussed enough and more of RTA. Refractory hypertension, hypokalemia, female patient evaluated for primary aldosteronism. This actually is an endocrine question. They are asking you for Conn's syndrome. Before Conn's syndrome, checking aldosterone-renin ratio. Nowadays, we are not looking for aldosterone-renin ratio. We are looking for PAC and PRA, plasma aldosterone concentration, plasma renin activity. But olden times, we used to look for this ARR. Now, as far as ARR is concerned, it's very clear, and we have discussed in endocrine also. 3 drugs we use to actually control hypertension, and all the other drugs we stop because they can all affect your ARR. Beta blockers can cause a false negative, others can all cause false positive, etc. etc. So, alpha blocker may be tried, verapamil may be tried, hydralazine may be tried. These are the 3 drugs that can be tried. In this question, CCB is there, alpha blocker is also there. So, these 2 options are actually speaking correct. What you are expecting, I don't know. There is no first line choice. I even went and read Williams' textbook of endocrine where they mentioned that any of these 3 drugs can be tried. But in practice, what most people try, if you ask me, is calcium channel blockers. If you talk to endocrine PGs, they tell you that they would mark calcium channel blockers. So that is what. But as far as the exam goes, as far as our theory goes, these 3 are right statements. In AIMS, I don't know what they are doing. But again, in AIMS, they are actually practicing CCBs. That's what the PGs have told me. So maybe CCB. That's the only thing that I can tell you. It's not a proper nephro question. It's more of an endocrine question. Yes. Then we had this question on differentiating SIADH and cerebral salt wasting, which is the single best method. So many options were there, exact options nobody remembers, but in very simple terms, let me just tell you that I have told this 100 times. Cerebral salt wasting is a cause for hypovolemic hyponatremia. SIADH is a cause for euvolemic hyponatremia. Cerebral salt wasting syndrome patient is going to be dehydrated, low on volume. SIADH patient is going to be having euvolemia. So because it is wasting polyuria here, SIADH will be normal to oliguric. But both are characterized by high urine sodium. Hypouricemia we use in practice to differentiate between the two. But remember, in both cases, uric acid is going to be low. But SIADH, it is actually going to be even more low. That's it. So the single best method, if you ask me, is volume status. What is the reason for cerebral salt wasting syndrome? We've actually discussed this. That is impaired adrenergic tone, decreased renin secretion, decreased aldo, and decreased sodium reabsorption. Dilatation of the afferent arteriole. Okay, that is one thing. That is impaired adrenergic tone to the nephrons. Second is increased natriuretic peptides. Okay, increased natriuretic peptides causing relaxation of afferent arteriole, direct inhibition of angiotensin, and antagonizes the action of calcium, vasopressin at the collecting duct. So in simple terms, if you ask me, the main point of difference is one is polyuria and dehydration and low volume. The other one is euvolemic. That's the difference. Uric acid we can use in practice, but for the exam, say both are low, but it is much more lower in case of your SIADH, where it is going to be in the range of 1.5, 1.6, etc. In cerebral salt wasting, it may be 4 or 5 that way. Yes, so that's about metabolism. Pediatric nephrology, we had a single question. What is the most common CACUT? Whether it is most common detected CACUT or most common CACUT, I'm not sure. But if you go with incidence and go with most of the studies, again, you can debate on this. Most of the places I was able to find that it is unilateral renal agenesis. In fact, in my class, I have told that 1 in 1000 live births, you do get unilateral renal agenesis. So I think that is the answer. Singaram has also told the same thing. Some people are debating that POV is slightly more common, but if you get a reference, please do show me. Most of the articles actually show that some hydronephrosis can be seen in the upper zones in normal children even. But if you're asked most common detected CACUT, it is still unilateral renal agenesis. So this is again a debatable thing, but from whatever I could gather, I feel this is the answer. This is the sole question from there. Test for efficiency of peritoneal dialysis, PET. So That is something which we have discussed in detail. I'm not going to that. Peritoneal dialysis, even if you skip and go, nothing will happen. You get maximum one question or no questions at all. And if that one question will be on peritoneal equilibrium test, which is a basically easy question. Okay, intradialytic hypotension, how do you treat? Intradialytic hypotension, we have discussed out and out. I told you it's a very important topic. This is the most common complication following a dialysis. And I told you that intradialytic hypotension can be due to basically 3 reasons. One is that you are having excess volume. Excess volume, because of that process in which you have to take out that excess volume, you are having to actually keep the dry weight too low. And keeping the dry weight too low, patient goes for hypotension. For example, 1 kg is your expected weight gain per day. You gain a lot of weight and come. So naturally, we try to increase the UF volume. When we increase the UF volume, we keep a very low dry weight, and the patient goes in for hypotension. That is one way of looking at it. Second way of looking at it is that there is lack of adequate vasoconstriction. So that adequate vasoconstriction that is actually being lost is a reason for hypotension. For example, warm dialysate, acetate containing dialysate, taking food during dialysis, tissue ischemia, autonomic neuropathy, or even antihypertensive drugs, all those things which can actually lead to lack of vasoconstriction. That's it. And then third is full cardiac. If you don't have enough cardiac, again you can go. So out of this, nothing seems right. Only thing is estimating dry weight. So not treatment per se, treatment is to give fluids, but like dry weight is very important. Dry weight is the weight below which you will start developing symptoms. If you try to remove fluid below that weight, you will start developing symptoms. So naturally, don't try to keep too low a dry weight, because that can actually lead down to hypotension. And you cannot keep a very high dry weight also, because then the patient will have volume overload. You have to check and find it out after the first 2-3 sessions of dialysis and try to keep it up. That's it. We have discussed that in detail. So excessive ultrafiltration, reduced cardiac output, increased tone, autonomic dysfunction, calcium channel blocker use, possible approach, alpha blocker avoidance, and phosphorus lowering therapy. Again, we have discussed this. Chlorine and chloramine removal. Chlorine and chloramine removal is part of your carbon filter. I have not even looked into the other options. We have discussed about the primary carbon tank, the polisher carbon tank, everything about this water system in detail. Hemodiafiltration, all are true except. So CRRT. CRRT, I told you the differences between hemofiltration, hemodialysis, hemodiafiltration, all this we have seen. Hemodiafiltration means that you are actually bringing to use 2 things, diffusion and ultrafiltration both. What is dialysis? Dialysis is a diffusion predominant thing with some ultrafiltration. This is diffusion, ultrafiltration. Dialysis, you are having only dialysate. Here you are having dialysate as well as replacement fluid. All that we have seen. Remove middle molecule cytokine. This is one of the major advantages. That is why we say that whenever you want to remove hypercatabolism plus volume, then obviously you are going for HDF. So HDF is going to remove your middle molecule cytokine, uses diffusion and convection, definitely uses diffusion and convection, removes all the molecules better than dialysis, removes phosphorus also better than dialysis, but the problem is that you will be losing albumin. So it's not better albumin nutrition. HDF is associated with more albumin loss and a poor nutrition. So you can actually see the differences that we have discussed in detail between hemodialysis. Then we have gone on to AK and treatment of AK. We have discussed this modality selection and the circuit and all these things. So hemodynamic stability, anemia, inflammation, phosphorus levels, all that HDF is better. By beta to microglobulin and albumin levels were significantly different. The long-term impact of that is because of albumin is also being lost because the pore size is high. So finally, the conclusion, that's what exactly the conclusion also says. For everything, HDF is better. We use HDF in CRRT as a part of a treatment for AKI in hemodynamically unstable patients. But the thing is that you're using dialysis with higher flux and higher KOA. Obviously, you are going to get something like a more molecule loss, more albumin loss, and more effect on nutrition. Transplant questions, 6 transplant questions. This is again a slightly tricky area. Test for BK virus with most positive predictive value. So before we see this question, let's see what we have studied. What we studied was this establishes a benign lifelong infection in the renal tubular epithelial cells or uroepithelial cells of normal people, and there is a reactivation followed by viruria, viremia, and BKV associated nephropathy. It can be a clinical or subclinical reactivation. First thing I told you was 25 to 30% of people can have viruria. Viruria does not mean anything. It has no predictive value. Hence, decoy cells also have no predictive value. So, if you look into this question, decoy cells, urine, BKV, DNA, both are having absolutely no predictive value. If you look at what has got predictive value, then this is your decoy cell. What has got predictive value? BK viremia in an asymptomatic person. If you see BK viremia in an asymptomatic person, bring down your immunosuppression. That is the only thing. Now, what can happen because of BKV infection per se means it can lead on to interstitial nephritis, it can lead to urethritis, it can lead on to cystitis, and sometimes asymptomatic increase in creatinine. Viremia plus increase in creatinine always reduce immunosuppression and consider a biopsy. Right? On the biopsy, what will establish characteristic cytopathic changes plus immunohistochemical test using antibodies against SV40. That has got a specificity of 100% or positive predictive value of 100%. The problem with biopsy, I told you, is that you need a medullary core. Second issue is that it is patchy involvement. So many things are there. But when you see the characteristic intranuclear inclusion plus immunohistochemistry using antibody against SV40, then you say that it is BKV. So BK viral nephropathy BKV in urine, no value. BKV in blood, again, just reduce immunosuppression. BKV in blood plus increase in creatinine, go for biopsy. In that biopsy, again, reduce immunosuppression, go for biopsy. How you confirm diagnosis? By cytopathic changes plus SV40 antigen assay. This has got 100% value. So now let us see the options. So two options we ruled out. Serum BKV DNA alone, does it have 100% positive predictive value? Never. Serum BKV DNA is just an index for your immunosuppression. When you are having higher BKV DNA, just reduce your immunosuppression. And the moment you smell infection, you take out MMF. They are anti-proliferative agents. They can be really bad. So that's it. So the answer for this question is Hoffen body. I didn't teach you what is Hoffen body. But if you know the others, you can come to the answer. What is Hoffen body? Is this. Hoffen body is actually something like a cast-like viral aggregate. This is called a polyoma virus Hoffen. This polyoma virus Hoffen in urine is now supposed to have almost the same predictive value. Sensitivity is almost like 100%, specificity is almost like 99%. So that Hoffen has got almost like a 100% predictive value. Okay, so the answer to this question is Hoffen body. I have not taught you what is Hoffen body per se, but Hoffen body in urine, which has got almost 100% sensitivity, 99% specificity. This is almost equal to biopsy is what they say. But if you know the other statements, I think you'll be able to come to the answer. So it's slightly tough question. Second question is, so stop antimetabolite, TAC 4 to 6, leflunomide, cidofovir, foscarnet, all these things have been actually tried, but IVIG is the only thing that has got some value. And always remember, very, very important DD4, we've discussed that in detail, acute T-cell mediated rejection. Tacrolimus is being replaced by sirolimus. What does sirolimus not cause as compared to tacrolimus? All the side effects of sirolimus we've discussed in detail. Hyperlipidemia is number one. Thrombocytopenia, leukopenia, anemia, hypokalemia, impaired wound healing, lymphocyl, oral ulcer, interstitial pneumonia, diarrhea, everything. Potentiate CNI toxicity, marked proteinuria, delayed recovery from ATN, thrombotic microangiopathy, reduced incidence of post-transplant malignancy, and not routinely used during pregnancy. Okay, I told you the advantages of sirolimus, the issues with sirolimus, when we have used sirolimus and its use as an alternative immunosuppressant, the issues with respect to side effects including impaired wound healing, lymphocyl, ulcer, interstitial pneumonias, proteinuria, all these things we have actually discussed. Now let's see what the question is. Proteinuria definitely is a side effect. Dyslipidemia, big time side effect. Fetal toxicity, it is not safe in pregnancy. Seizure is not a side effect of sirolimus. Neurotoxicity is a feature of tacrolimus. What differentiates tacrolimus from cyclosporin itself is that tacrolimus is called alopecia, neurotoxicity, tremor, all those things. Foot drop, wrist drop, and those things. So the answer is seizure. If you've studied drugs in detail, it'll be a very easy question. We cannot go for any exam in the country without studying drugs in detail. 15 months post-transplant female wants to conceive on triple drug tacro plus AZA plus steroid. What is the next step? Nothing. You don't need to change any of these things. Okay, MMF, sirolimus are the only things that if present you have to change. Otherwise they are safe. 15 months post-transplant, you can definitely go ahead. It's more than 1 year post-transplant. There's nothing. Continue the same immunosuppression. Minimum recurrence post-transplant by graft loss. I don't know exactly whether they mention post-transplant graft loss. I have done a single module 20-25 minutes on recurrence post-transplant. It's a very, very important question. And we have looked at each of these things in great detail. Membranous, membranoproliferative FSDS. I told you about FSDS recurrence and the importance of plex in that. I told you about 20 to 50% recurrence of FSDS in children, of which 40 to 50% you can have graft loss. Membranoproliferative, where we are having type 1, type 2. Type 2 has got extreme high risk for recurrence, 80%, but graft loss is less. Here 20 to 30% recurrence, but graft loss is more. SLE, I told you, is got 10 to 20, SLE 1 to 30% highly variable, graft loss is very, very, very rare. Okay, so simple question. It is lupus nephritis, least graft loss. Please go and see that in detail. I have told you about the risk of recurrence. IgA, for example, has 60% recurrence in biopsy, of which only 20% has recurrence in the graft, of which only around 10% will have graft loss, etc. So everything we've discussed in detail. And DDD has almost got 80 to 100% recurrence in graft, but again, graft loss is per se only 20 to 30% and all that. So lupus nephritis is on a broad range, recurrence 1 to 30%, but graft loss is rare. So that's the answer. Okay, so that's it. Transplant questions are generally very simple. This is the one tough question. All are indications for combined liver kidney transplant except Primary hyperoxaluria is the indication for liver kidney transplant. We have kept on repeating 10,000 times. Everybody will know that. CLD with ESRD, you can think. CLD with ESRD, of course. So this is also right. The problem is with these two options. Mitochondrial diseases about which we have no idea. CLD with HRS on dialysis for more than 8 weeks. I myself have taught you, and everybody has taught you, that HRS is a disease where kidney is full normal. So even if you take out the kidney and transplant, there is no issue with respect to the kidney. So why should you do a combined liver kidney transplant for a patient who is on HRS? You need to transplant only the liver. Why should you transplant the kidney? And that's why almost everyone marked the answer as B, which is very, very reasonable, because mitochondrial disorders, we have no idea. But when you look into the data and we look into the indications for a combined liver kidney transplant, in a patient with liver disease, CKD, of course, we have to go for. Kidney biopsy showing more than 30% glomerulosclerosis or tubular atrophy, you have to go for. Any form of AKI with the creatinine requiring dialysis for more than 8 weeks, you have to go for. It's very sad. I have not taught you this. I myself did not know this. So if you ask me, I thought that probably because it is HRS is 8 weeks cutoff, I didn't know. AKI I knew, but inside that AKI, HRS also comes. So mitochondrial disorders, because I know that mitochondrial disorders have been associated with a very, very, very poor result with respect to transplant, I would have marked this answer. But for that you need to be knowing mitochondrial disorders. That's because I had a study on that and written an article on that, mitochondrial disorders and AK and stuff. So because of which I knew that mitochondrial disorders are disorders for which transplant is not an option by any means, whatever be the transplant. So I would have marked this, but otherwise between these two, very likely to get confused. It's a tough question. Okay, so the answer to that is indication except mitochondrial disorders. Okay, so you expect that in names. Okay, anti-HLA antibodies are produced by all except. Anti-HLA antibodies are seen with pregnancy, transfusion, transplant, never with vaccination. Simple, very simple question. Okay, we have discussed that so many times. Question on CKD, EPO resistant anemia caused by all except. The moment you think about EPO resistance, I have told you this so many times, EPO resistant is 300 units per kilogram per week. The moment you have EPO resistance, what do you think about? When I see EPO resistance, I told you I think about three things. First thing that comes to my mind is inadequate dialysis. Second thing that comes to my mind is iron deficiency. Third thing that comes to my mind is ongoing infection, inflammation, wound, catheter, this and that. So under dialysis, iron deficiency, infection, inflammation. Then we have also discussed blood loss, hyperparathyroidism, aluminum toxicity, B12 deficiency, primary bone marrow disorders, ACE inhibitors, etc., etc. And this is something that I have told you so many times. It should be a very easy question. Aluminum intoxication, iron deficiency, it is hyperparathyroidism producing bone marrow fibrosis. Nothing to do with hypoparathyroidism and kidney. It's all about hyperpara. So it's an easy question. This is not easy. Which of the following metabolic abnormalities would be seen with ferric carboxymaltose administration? Ferric carboxymaltose or IV iron administration, especially ferric carboxymaltose, has been associated with hypophosphatemia. I have not discussed this. I have not taught you this. I have shown the table on causes of hypophosphatemia. I told you that hypophosphatemia can be due to only three reasons. One is we are losing phosphorus. Second, we are not taking phosphorus. And third, phosphorus is lost from the blood to the cell. We are not taking phosphorus is basically endocrinologist's cup of coffee, not got to do anything with nephrologist. Nephrologist is mostly concerned with increased urinary phosphorus excretion. Increased urinary phosphorus excretion has got to do everything with FGF23. Phosphorus loss in urine is all about FGF23, and I have told you how that actually manifests. You can have FGF23 is the most potent phosphatase in the body. So you have something called hypophosphatemic rickets. This hypophosphatemic rickets, I told you, can be because of FGF23. It can be because of PHEXD mutation. It can be because of divalent metal protein 1 mutation, DMP1 mutation. FGF23 is autosomal recessive. DMP1 is autosomal dominant. FEX is the most common, that is X-linked. All this we've seen. Tumors can produce FGF23. That is called tumor-induced osteomalacia. And that can lead to hypophosphatemia, rickets-like manifestation. All these things we have seen. Okay. Also, I have told you about Fanconi, where you can have hypophosphatemia. Then, of course, drugs, including diuretics. And here you can see IV iron, but I did not mention this. Something which I knew because we have had discussions on iron, but I didn't tell in class. So that's about hypophosphatemia. It's a slightly tough question, which many of the people were not able to answer. You can see over iron carboxymaltose increases FGF23, increases phosphorus excretion. But in practice, we use a lot of iron carboxymaltose. Whether it is associated with this is a question mark. Okay, that's it. Those were the only two questions. Nephro-uro overlap is something which I felt bad about because I have not. There is a chapter in PHALI called Urological Issues for the Nephrologist. In fact, that is the only chapter in PRL which I have not discussed because I felt it's not important. It's more to do with the urologist than the nephrologist. But unfortunately, we got a couple of questions from there. Let's see the first question. Primary hyperoxalosis treatment. I did not discuss treatment of primary hyperoxalosis as such and not a part of glyoxylate pathway. Two really tough questions. So this is what it is. This glyoxylate pathway is one where glycolate is getting converted into glyoxylate. This glyoxylate will be converted into this glycolate and oxalate is nephrotoxic. So oxalate is nephrotoxic. So this lumasiran is a drug that is now being approved. See, the problem is that in a disease like hyperoxaluria, you are having alanine glyoxylate aminotransferase deficiency or you are having pH1 defect. Alanine glyoxylate aminotransferase actually converts this glyoxylate back to pyruvate. Okay, it will convert glyoxylate back to pyruvate, and because glyoxylate is going to pyruvate, it will go to some other cycle. Suppose you are not having this enzyme, then this glyoxylate will go to the hepatocyte and then go to the cytosol. Now glyoxylate production can be decreased by inhibiting this enzyme called glycolate oxidase. Okay, glycolate oxidase. Glycolate oxidase is actually inhibited by this drug, and that is the drug which asks for your exam called lumasiran. It's a very tough question. So now we come to this question. This question is also very tough. Now you know the answer because you just studied the pathway. So what happens is that we are having something called glycolate. Glycolate, there is an enzyme called glycolate oxidase. Glycolate oxidase converts glycolate to glyoxylate. Okay, glyoxylate. This glyoxylate is the problem because glyoxylate will go on and convert itself into oxalate and again it will convert into glycolate. Okay, in normal course, what happens to this glyoxylate? Glyoxylate gets converted into pyruvate. Okay, and it will also get converted into glycine. So glycine and pyruvate. So it does not come into the oxalate pathway. So glycolate is correct, oxalate is correct, glycine is correct, glutarate is not a part of glyoxylate pathway. It's a tough question. I now feel that I should have taught you this whole disease in a lot of detail called primary hyperoxaluria because there were 3 questions in fact. One was combined liver kidney transplant, which I have discussed. This I have not discussed. This also I have not discussed. But in INICET you expect this. These are really tough questions, and I'm sorry that I have not actually discussed this pathway because I felt it was not important for a nephrology person to know, except to know that oxalate nephropathy and those things which we have discussed in great detail. But as a part of this pathway, etc., I never expected a question would come. And then lastly, this all are false about uric acid stones. Stones also I have not discussed in great detail except for medullary nephrocalcinosis, cortical nephrocalcinosis, etc., etc. There are 3 reasons for uric acid stones. First reason for uric acid stone is low urine pH. Second reason for uric acid stone is low urine volume. Third reason for uric acid stone is increased uric acid in the urine. These are the 3 reasons for uric acid stone. So obviously when you treat, you have to increase the pH, you have to increase the volume, and you have to see for if there is something that can be done with respect to uricosurium. So alkali treatment reduces the recurrence, 100% right. It is the most important part of our treatment. We don't go for sodium citrate, we go for potassium citrate. Never seen on a radiograph, it is actually a radiolucent stone. Xanthine, indinavir, triamterene, uric acid, situ stones are actually radiolucent stones. Allopurinol is always used in treatment now. That's only when your basic treatment is not responding, then only you go for allopurinol. It is not always used in treatment. It is not mandatory to treat with allopurinol all the time. So low urine pH, especially high animal protein diet, insulin resistance, low urine volume, hyperuricosurium, which you see with excessive dietary protein, gout, myeloproliferative disorders, tumor lysis, Leishman syndrome, etc., etc. Okay, so this again is a proper urology thing, stones, which I have not taught. Drugs that can be associated with nephrolithiasis, nephrocalcinosis. Here you can see uric acid stone, salicylate, probenecid, melamine. These are the 3 things. Okay, calcium stones, we have discussed most of the things. Steroids can produce calcium stones, acetazolamide, amphotericin B, topiramate, furosemide, vitamin D, because all those increase hypercalciuria, so you can actually take it that way. All of them produce stones. And causes for cortical and medullary nephrocalcinosis, again we have discussed. So nephro-uro overlap is one area where I felt bad because I think I should have taken a module on that. Primarily because again I thought these kind of questions generally for NEET they don't come. So in SS we had 3 questions, but rest of the things I'm pretty happy because we've discussed most of the stuff. Few things have just come above board, like the hammer shield regime or something like your soluble or membrane bound complement factor, or things which are like hypophosphatemia producing, hypophosphatemia result as a result of iron pericarboxymaltose injections and stuff. Those are slightly tough, but apart from which I think out of the 50 questions, 40 are very easily manageable. If you use a bit of sense, I think even 42, 43 are manageable, but the rest of the questions are slightly tough. But there are people, I think, who have scored up to 42, 43. Very few though, but most of the people were able to manage around 40 very easily. And of course, you have your share of silly mistakes here and there. So overall, I felt it is a standard NEET SS paper where we need to know everything in and out. But once again, in the remaining few days prior to the exam, I would want you to actually stress on certain areas. The most important areas that you are going to stress on are, there is nothing in nephrology without glomerulus. Glomerulus is the single most important chapter where everything we need to know. As far as tubular indecision is concerned, autosomal dominant polycystic kidney disease is that very important topic which you have to be knowing everything about. And also the comparison with hereditary cystic disease of the kidney, nephronophthisis, and its comparison with autosomal recessive polycystic kidney disease. This is very, very important. Okay. When it comes to HUS, TTP, please look into the other secondary causes of that, especially the drugs and those things. Please try to look into, because we get questions from there. Transplant, always keep in mind BKV, CMV, one sure short question. Drugs in transplant, a sure short question. Recurrence in transplant, a sure short question. Mostly something about acute T cell mediated rejection or antibody mediated rejection. Again, the modules, whatever important points that we have stressed on. Dialysis, generally you don't get much of questions. Just try to focus on HD, HDF, then HF, the differences between these terms, etc., which might be sometimes confusing for you. Then going into AKI, AKI is a huge topic from where generally we don't get so many questions, I told you, for the exam. Try to look into ATN, acute interstitial nephritis, the causes for ATN, the causes for AN, the difference between ATN and AN, and sepsis as a single cause. Okay, so these many things I feel are very important. And calculation of GFR, the importance of cystatin C, some important points on renal physiology, all those things. So I think which you can actually complete. And if you do get time, please read that chapter called Urological Issues for the Nephrologist, because 1 or 2 questions have come from there. Okay, so I have tried my level best to look into every single topic inside nephrology. I want to be very sure that questions generally don't come outside what we have dealt. And those 45-50 hours that I have done, I think 50 hours or so, should be good enough for you to crack any exam in the country, provided you are having interest, zeal and momentum with respect to the subject, because it's not a routine kind of a subject. If you ask me personally also, I feel nephrology is not exactly like how medicine is. We were taught during those times that it is a continuation of medicine and stuff. I don't feel so. Except for the general nephrology part where you're having something to do with medicine. It is a new science. It's a different science. And a very interesting science. Very engaging science. And I feel you need to be really blessed from above to get an opportunity to study this subject. It's a very, very, very manly science also. It's a very interesting, engaging, manly science. And it's a science which helps you be on your toes every single time. And you feel like you are doing something. Yeah, feel like doing something and feel like you are doing something which can be of use to the patient also. So that's about this. In the remaining days, just try to focus on these areas and we'll try see how the paper is. And so wish you all the best for your NEET SS exam, and keep me posted with respect to the questions. We can try doing similar discussion like this after NEET as well. Thank you.